Good morning, everyone of you. Well, the idea today is to show you the use of photobiomodulations with the transcranial technical for the neurologic disorders. I am a former full professor of Diffísio UFSCar with these characteristics. So fundamentally, what we have is the use of laser of high or lower intensity, or LEDs, the light emitting diodes, being applied in different tissues of the human body. Today we're gonna focus on neurons, and we aim to see how it works. Photobiomodulation works with ultraviolet radiation through all the visible spectrum and the near infrared, which is being largely used nowadays. And when we use it from the perspective of the mechanisms involved, we have fundamentally three main effects, but there are other two associated, and amongst them we have the biggest expression, ATP. There is an increase in ATP, mitochondrial ATP. There's also an increase in the concentration, a fast peak in ROS and also of NO. Each of these answers end up by creating secondary answers, secondary responses. They are broken down in secondary responses with very important consequences, effects. These mitochondrial effects, as I said before, fundamentally in the chain that transport electrons in the Krebs cycle. This is the action happens in a mitochondrial level, but there are also actions in the cell membrane. They are connected to ionic channels that are altered in terms of transport through signalization, and they end up by activating the transcriptional factors in the nucleus, leading to important responses in cellular level. And even the mitochondrial responses end up leading to the activation of transcriptional factors, as I said before. NO is liberated, is released during this process, and ends up in the cellular level, the extracellular level, that will activating these transcriptional factors. So, long time ago, Nikola Tesla showed that the brain is a receiver, a very good receiver, a very interesting one, of electromagnetic energy. And we have examples of this, such as in the case in the birds that can direct themselves when they're flying during their migration period, because of reactions in the brain, and they come and go to the same places with the same localization and so on. When we are talking about photobiomodulation in the brain, we have to understand that first of all, the light has to come in and arrive to the neurons. There are some papers, and I've put here one of them, but there are several others demonstrating that this is compatible, this is possible. And this paper shows that near infrared and infrared can arrive to some structures in the brain, such as the pituitary gland and other places in the brain. And they've performed a series of measurements showing that light arrived to levels that are compatible to stimulation, which is this case we're seeing here. In red, we have the third ventricle, starting with the initial amount, initial value, 40 milliwatts per centimeter for a square centimeter, and we have 95 milliwatts per square centimeters. The first papers were created for experiments, were created in a very experimental level. This was done by Michael Hemblin in Harvard. Injuries were created in rats' brains. They were standardized injuries. And we have a normal brain for a healthy mouse. And here we have an injury that was not treated with light and another one that was treated with light. And what we see is that a very important recovery factor in that place in the brain that was traumatized by using the light treatment. And he offers some important mechanisms. There are some other experiments, of course, but this one shows that in brain injuries, brain traumas, there is the possibility of reducing edema and inflammation, acting in some parts of the brain, increase of angiogenesis, increase of neuron progenitor cells, the neurotrophins are increased, and there is a reduction in the levels of apoptosis and necrosis, and as well as a reduction of excitotoxicity. And this is very interesting in this case. These features allow us to do it in clinical level. And today we have a series of studies that demonstrate it, that show it. For instance, SOD and HSP 70, and also some transcription factors, including survivin, which is a very important substance for the survival of the neurons. All of them are increased because of this action in the mitochondria. These responses lead to a pro-survival response from the brain. Then we have different possible techniques to arrive to the neuron. We have the technique that I already mentioned, by using the light, crossing all the structures until the bone, and arriving to the membranes and to the brain. But there's also the possibility to do it oral, intranasal, and also the possibility of using an invasive surgery. But this is not the best way because you have to open the brain and you may be subjected to infection. The best thing is to use a non-invasive procedure, and these techniques are already characterized in literature. All the effects that I have mentioned before, I'm not going to repeat them because we are short in time. Some studies here from Professor Gonzalez Lima in Texas showing that, for instance, by applying it in a prefrontal region of the brain, he achieved Here we have the experimental scheme that he wrote down, the measurements that he took, and at a certain time, at a certain point, he used the photobiomodulation. And he performed a series of checkups in specific events, and he used FNIRS that we learned yesterday, the FNIRS technique, characterizing what was happening in those specific regions of the brain. And that was very interesting. For instance, let's see here, he was undergoing tests, he was performing pre and post tests, and during photobiomodulation, he had a higher number of positive events with a higher concentration of hemoglobin after photobiomodulation, what shows clearly that we had enhanced blood circulation there. This is the same experimental group performing and using the prefrontal again, showing the concentrations, different types of concentrations, and performing and checking elderly and young people, and they noticed these different responses, because those brains from elderly and young people are of course different. And he noticed that different responses coming out of it, but both of situations were using or benefiting from photobiomodulation. This is the FNIRS that we saw yesterday, modulating the encephalographic rhythm, the electroencephalogram rhythm. And it changes these characteristics, and we have this mapping, the mapping of the situations of these changes when we perform the photobiomodulation, leading to a more smooth situation for these individuals, smooth in the sense of levels of stress and so on. There are different applications, not only for this situation in terms of cognitive action, but also it can be applied in other situations. We see here an increase in the concentrations of using FNIRS in M1, the primary motor region, and here also checking the MRI, the functional MRI. Sometimes I just have this, my old brain works differently. So functional MRI using bold that allows for more detailed detection. And there was also in some regions that were especially chosen, there they used a specific laser, and they found an increase in functional connectivity of the brain. In 151 places that they analyzed in the brain, they were able to there were an enhancement in these regions, an improvement in these regions. And this shows how he detected, how he analyzed all these brain regions as described here, showing that through illumination there were significant differences in terms of brain functionality. And so there was the most interesting thing is that he performed a thermography, and there was no significant change in temperature, which is very interesting. So what's the idea here? Is to go on through all this process to increase neurogenesis and synaptogenesis through BDNF, improving conditions for regeneration and improvement of the conditions of the brain conditions for these individuals. Many studies were performed. This was the first one with ischemic stroke, showing that there was always an improvement in average, a very important improvement that speaks to photobiomodulation. These are some case studies that were not the best evidence-based studies, but they also changed they also show that was a change in the features of the brain, and this was very interesting. I was able to take part of the project, but I was not working during the data collection part. And it's very interesting to see this study regarding traumas and different radiological characteristics. It was published in Science journal, and here we have 19 participants, and we have the individuals that received light and the ones that received the sham. Of course, I don't intend that you will be able to read, but I want you to see that there is this, similarity between these individuals. And they performed a very detailed analysis through RMI. And here you have a change, a very important change, and it was the first clinical trial showing that in humans they had different parameters regarding photobiomodulation with very strong evidence. And here the continuation of this research, and the conclusions are that these patients were assessed in the pre-moment where they were clinically stable. After hemodynamic stabilization, they performed a first assessment, and then 1 week after, and then 6 months after, with only one session after the first assessment. So they had very interesting results with just one simple session. I'm gonna run a little bit here with the autistic spectrum. Many aspects that were raised, and always photobiomodulation showed much better results. And in several situations, each of them showing possibilities of more evidence regarding one or other aspect that was impacted by photobiomodulation. So many articles, I'm just going through them quickly. Many articles were published with several. I'd like to show you quickly a study that we performed with using thermography and photobiomodulation. And we worked with stroke with more than 12 months since onset. We had inclusion and exclusion criteria. We did thermography and photobiomodulation, and we wanted to know regarding these patients with electrostimulation with already some effects detected, if they would have improvements with photobiomodulation, and performed a series of measurements What we have here is that the group treated and the placebo group, and we checked to see if hair was interfering and the fact that the light was arriving or not to the brain. There are some differences here, but it's not so different to if compared to the if we compare the situations with or without hair. It didn't change that much. What we have here, according to the assessments, I will only highlight the differences. Something regarding something regarding the calculations, the dexterity, the frontal cortex, life quality, quality of life, social relationships, and regarding these life quality questionnaire, the total score was impacted, and the sensation. The sensation of the well-being sensation also was impacted. So there was an increase in temperature in the treatment regions, and also in the localization where the photobiomodulation was applied, there was an increase in temperature too. Also, the pain scores were improved, and the general minimental was impacted. And in this very same study, we checked to see what happens if the light would actually arrive to that part of the brain. We studied corpses. Just to finalize here quickly, you have the possibility to perform transcranial, but also using photobiomodulation in a systemic way, and we can also perform it, for instance, in the abdominal region, or also in a thicker vein in order to stimulate the blood there during the photobiomodulation. Of course, we need a longer period of irradiation for that. And lastly, we have to do so that microglia and other cells, we see that they change their character from inflammatory to anti-inflammatory, and we arrive to the possibility of doing everything that I have mentioned before, all the effects that I mentioned and others that are being introduced. Fundamentally, that's all during the complex 4 in the mitochondria. That's where the magic happens. So photobiomodulation is a strategy, but we also have TDCS, RTMS. Exercises also are important. It's safe and tolerable, so we can perform it normally. And to conclude, there are already described applications such as in Parkinson's, Alzheimer's, post-traumatic stress, depression, among other possibilities. We improve brain neuroplasticity, and we have strong evidence of that. That's all. Thank you.
Thank you, Professor Rivaldo. Let's talk now about technologies on the terms of the movement. I would like to call the professor to do your presentation. Thank you for your invitation. It's an honor as a clinic to be here. What is new on dress technologies and the terms of the movement? There's no conflict of interest to this lecture, and before I talk about this theme, I need to do a brief summary of where we can use this technology. They result on the compromising of the motor system that controls the motomatic movements. And when there's a big defect in this area, there's two. You have the syndrome rigid, synetic, or Parkinsonism, or what we call hypersynetic. So the Parkinsonism is a combination of symptoms. We talk about it basically about motor manifestations, and we know that these are motor ones and not. And the most cause is the disease of Parkinson. It results on motors where we can have the where we have the sorry, I'm not getting right here with the slides. So we have here the kinetics, where we have the amplitude of the movement, the shaking, and the roughness. These are the symptoms, the motor symptoms we have, and the no motor symptoms we have the clinic picture of Parkinson. And you may have fatigue, some autonomous manifestations, constipation, and other psychiatrics like anxious, depression, and cognitive problems, and some bad sleeping, a lot of excessive sleeping. Around these manifestations, we also had, especially remember from the constipation that is the premotor symptom. This is the combination of symptoms and signs we can see on Parkinson's disease. And the kinetics, we see that there's the poverty of movements. We see the presence of abnormal movements like the patients couldn't control, that we see as the what is a normal movement. I call this a shaking. When is wave movement, especially on the toes and the fingers, you see a movement. Remember, dance is Korea and myoclonic, and also the tick. We have stereotypes and also sound ticks. You have the throwing up of the body, and you have dystonia, like you have a distortion of your body. And where we're going to use these technologies. So basically, on the Parkinson disease, it's when you see the Korea and these terms of the movements, we can see what is the wearable technologies, disposals who are advanced in clothes or in belts or in shoes or your clocks. They were connected with other equipments with software online. Mostly is the smartphones. What is the advantage of the wearable technologies, especially here on the motors dysfunctions? It can monitor the patients on her daily routine, as if we go to a party either. Because in the hospital, I tell to the patient we see the picture, but the families on the routine, they saw a movie. So the wearable technology allow me to see the patient as a movie, not just a picture, and the determine moments of his life that may not correspond to what happened on the routine. And to quantify how it marched and the bradykinesia and the trembling and the complications of the response therapeutic. We know now that what we call all motor dysfunctions that can occur after some years of treatment do not result of medicine, but it's the combination of the medicine with the time of evaluation of the disease. So we can quantify better with these technologies what type of dysfunction occur, and of course the therapeutic answer I can give to the treatment to the patient. So let's remember the target is specifically to motor problems. So let's see we can easier the access to patients that live far from urban centers because they do not have access to neurologists and other specialties. So it allows you to subspecialists could also collaborate with this patient, and maybe it will reduce the number of physical medical visits, so the doctor could do a monitor from his house. So because it's difficult to the patient sometimes to walk to the doctor. And the other advantage is this: in general the humor of the patient is going to influence a lot, especially about the Parkinson disease, because it's my patient. It takes with our this t-shirt to the my room. He is a professional complainant, so he's always bothered because he could not offer anything good because he's always on the half empty glass. So with this technology, maybe you could take this patient who are the moments they are more happy, optimistic. So it's another great advantage of the wearable technologies. Some way I could. So the technology is basically sensors and inertia measurement unities. In general, they are gadgets we can use on the fist, we can use on the arms, we can use at the ankle or the lower back, and this is going to help us to characterize some motor functions that I said before. So the objective, I can use this for diagnose or for rehabilitation, but I'm going to focus on diagnosis now. So what is new? On the disease, we have on Parkinson the intelligent shoes. So we have a rigid sensor to analyze the position of the foot that it's predefined is a biomechanical analysis. Is going to measure the length and the velocity of the walking of this patient, know how its walk is more developed or if there's any complication that we call freezing of gait. That it's one of the factors that bothers more the patient, that interferes in the quality of life. So all of this is going to help me. I can also have this on a fist where it can help me to do a diagnosis. They are defined on fluctuations and synergies, synetics. So we are going to see the ideal dose of medication I can see, and the fluctuation we can help it, the other way because I do not get to the right point of the medication. So there's ways that this technology may help me to evaluate it. So And during the walking, maybe in the future you could have like you can do sooner diagnosis. We have the you can put in the shoes some inner soul that going to accelerate and sometimes have navigation and the change on the magnetic field and going to analyze the risk of fall on patients that falling a lot and even the patients that do not start falling and to prevent them to fall in the future. There's a big technology that I can have. And this system they're integrated with smartphone and smartwatch. The biggest advantage is to prevent the patients to fall. I suggest you to read this article from a physiotherapy specialized in the dysfunctions of the movement. He's linked to a big group, the Dutch group. They started a long time ago studying this area, especially on Parkinson's disease, and they talk about assisted technology in Parkinson patients. Accelerometers that could detect interruptions of the sleep because they used to have bad sleeping. And I'm not going to trouble you with this slide, but just to show you that the most of the studies we do with the wearables, they going to use the and another disturbance you can do is the Huntington disease. It's in the Korea movement because when it's a movement of dance, it's going to interfere a lot on the walking. And this patient spends half of the day laying down. So, besides what we thought, patients stay much more time lay down than the Parkinson patients. So we need to see where the time that the patients stay most laying down and see in the essential trembling, like in the Parkinson's movement. We can also prevent to the trembling. And then what is our limitation? There's a lot of devices with algorithms. There isn't any pattern. So how I could compare these results? Patients and caretakers, they are enthusiastic with the idea, but they are not familiar with the technology. So the difficulty to deal with the technology from long term, they generate frustration and enthusiasm and loss. And a long time ago, a patient gave us a device that was relatively easy that you just push a button when you feel the action of the medicine dropping down. And I remember I gave it to a patient of mine who are psychoanalysts, and he had some difficulty to deal with this device, a needs device. So imagine a patient has had more problems to deal with technologies. So unfortunately, this is a limitation we have. So access and velocity to access to acute pattern could be an obstacle. Another thing is the lack of evaluation and how much cost a smartwatch, the benefits we have. So I do not and do not own the Apple, but I know there's a smartwatch from the Apple. They are cost a lot, but even the ones that cost less, I know that some patients may not pay for it. And the other big problem is something that we do not have some conscience about it, is the secrecy around the data that were being collected from the patients, and had a lot of difficult to give who the patient is going to give this data we collect them, who is going to have access, and what they're going to do with the security with this data. So what is your challenges then? The app should be friendly to the patients and also to the health professionals such as me or the others that follow my patient through the treatment, to analyze and to condense the generated information, especially if they are in environment that are not supervised. So there's a lot of information we can receive with this device, and we don't know how to deal right with the amount of data. And when we talk about a algorithm on this device, they hear a lot of data and complex algorithms that are involved, and we don't know how to use it right. And we need this to see more on patients who do not have this diagnosis, with patients who do not have a diagnosis. So it's another difficulty. We have also ratio of symptoms that are not motors, because you could see a lot of manifestations I could monitor. So this device could not do this evaluation of 10. So the other works that I do, there's the no amount of hard evidence, have the follow up for long term of smaller samples is also a challenge, and the integration with professional doctors and professionals of the health area, and also the engineers, because they don't talk to the other, because doctors do not understand like engineer how this device work, so they need to work together, the engineers with doctor, physiotherapists, and the other professionals, so we could understand better the necessity of both. And what do we have to the future? Try to identify the patients who we call patients who do not have the diagnosis, with clinical trials, and to detect the fog and stability on the posture and the balance of the patient, and to work especially for rehabilitation for patients who do not have access to places who have this rehabilitation we can do personally. And talking about technology, I don't know if you know the open evidence. It's an AI where you put your questions and they give your answers. So when I put the theme of my presentations, he only revealed me these articles. Turning out if this AI only show me these articles, it's the top that he can only give me these articles, or he didn't talk about the Dr. Tamini article. So I don't know if I didn't research right, or the AI doesn't know how to suggest me properly. So in the beginning, what you see on the PubMed, when I did the first research, I found 103 articles, but I thought that maybe we could find more than 4,000 articles if we saw other sources. So we needed to be trained to use the technologies, because we have this difficulty. And I said that in less than 40 years, only one who can have more than 50 years here in the room is going to understand that I left the area of the Flintstones to the Jetsons. We came to the we got to the place I thought it would not be possible before. So I'm a neuron from previous internet, previous to the computer. I need to enter in the AI now. It was so fast. So what you need to take home because I need to enter now. Where is my patience? You couldn't not lose our patience. The technology is going to help us, but I still need to say the professional it's not going to be substituted by the AI. It's not only going to help me and not going to be substituted because the AI could not give you empathy and caring. So we cannot be replaced by them. There's a professor who created a long time ago the clinical aspects we should use to the diagnose the Parkinson patient, and he said that empathy, the machine is not going to replace us. Thank you.
Thank you very much. I'd say that this generation is very fortunate because it received all the changes and advances that we had, and also the disadvantages as well. So let's move on. Now we have Professor Dr. Denise Flavio that will talk about orthopedic workshops, rehabilitation, and care for people with disabilities. Good, good morning, everyone. I hate workshops, and all these technological advances are important, but most importantly, how can I make so that all these technology will arrive to the maximum number of people I can? In Rio and in Brazil, we have a network that is a process through the health ministry that coordinates this care, this assistance network to disability people with disability. And within this process, we don't have only health professionals, but we have engineers, architects. We have more than only health professionals. It's a regionalized network coordinated by the state secretaries and the city halls, the city secretaries. I I can only create an orthopedic workshop if I work in it. It receives funding from the Ministry of Health and funding from the municipalities. And I'm gonna talk about how we can help people to receive all these technology and a transformation we're being observing in the world. So when you decide to create a space that works with rehabilitation, you have to create a project and send it to the Ministry of Health, the state secretaries, and once approved, we will have financial incentives. Not that you can not do it privately and create those spaces, but for you to become regional and be regionalized, you have to go through all this process that has been evolving. We have our normative landmarks, the main ones, that have been improving, and we've been involving in terms of legislation. And all these ordinances are about increasing the number of personnel working in human resources. And the Ministry of Health has been investing in training so that we can grow our workshops, and I'm gonna give you the numbers. We have cities in Brazil, states with orthopedic workshops that are trained, well structured, but they are not working because they don't have personnel. They don't have human resources. So we still have a lot to work on. So all these ordinances talk about restructuring of the human resources, the professional, the staff. We have the unique modality with one center specialized in rehabilitation. The ones that already exist will remain, but now we are prioritizing health centers with more than one modality: intellectual, physical, auditive, and visual. They are grouped by region. For instance, Metropolitan Region 1 in Rio, Baixada Fluminense, the city of Rio, the Broaden City. The 15 municipalities gather, and you will establish where these centers will be to assist the maximum number you can, because these centers cannot exist in one per municipality. This is not possible. You have to establish which municipalities you will choose for the centers, and they will receive the centers, and all of them receive financial benefits. They receive these financial benefits according to what was designed in this through these ordinances. You have orthopedic workshops that are defined also by region, and you have also financial incentives. It's not possible for each municipality to have an orthopedic workshop. These are the landscapes the landmarks in terms of the milestones of our ordinances. When you have can offer a good service, you really don't lose money. This is the organization of our care units. We have primary, specialized assistance, and emergency. We are here. Orthopedic workshops, orthopedic units. It's a huge network, and we are a small dot inside this network. But it's not less important than the others. It's quite the opposite, actually. We receive patients that often do not arrive to primary care. So when we're talking about primary care, if I have a basic unit working, and if I do not offer a good job there, I'm going to have a large number of people that I will arrive to the centers with disabilities. If I had a good job being done at these primary care, this would be different. People arrive there without perspective. For years, they remain like that, and this is not possible. I have to make sure that this person will arrive there. And how can I also dismiss the person? So this network cannot work if it's not related, or if it's not being related to other secretaries and the state bodies and the federal bodies. If I don't have, for instance, the sports secretary with me, if we're not working in a very integrated way, this is not going to work. This is a simple observation and very important. The number of people, children, that arrive with to us with problems at school, it's huge because I don't have a phonoaudiologist, a physiotherapist working inside the Secretary of Education. This is a professional role that's not required by them. And since they say they don't need it, I cannot send one to them. So we have to create bills of law that will create the need for these professionals. All these secretaries need to work together to make this work. And it will be very hard for me to make so that these people will have the care that they need. This slide can be used for us, can be used in a whole day discussion, for instance, because we have so many other issues that can be integrated here. I have a very big network of people with leprosy, and they need the orthopedic units, the orthopedic workshops, and they are not integrated in this care project. These numbers are from our 2023 numbers, trying to broaden, to spread these networks. We're talking about public networks and also philanthropic institutions. We have 48 orthopedic units. Some of them are not really working because they lack professionals, and we have to work on this. I have some unique modality services that are working, and I have here CER2 and 4 and orthopedic units. I have a huge investment, governmental investment, and not only to build but to maintain and buy equipment. So I can buy all these equipments with fiscal incentives from the Ministry of Health. I need a good management that will work in an integrated way, that will have the knowledge and be able to talk to the government, because I can receive parliamentary amendments. Through them, I can get my equipments. But even so, I am not able to serve a big part of the population. So I need to improve this work and integrate the managers to this work, invite them on board, because this is easy to work in this network. I have to have people who will go to the manager and show the facilities. Our government has a lot of problems. No. So we cannot take problems to them. We have to take solutions. How can we find money? How can we organize ourselves within the network, within the structure, so that we can get the benefits? We have orthopedic units that are already developed, that have a lot of equipment. Through parliamentary amendments or public calls, the public network has to call. It's not impossible. If we take into consideration, I'm already arriving to the end. If we take into account the orthopedic units in terms of cost, the cost of having these units is. Do you know, by the way, how much a prosthesis cost, for instance, for the femur? To the Ministry of Health, if through a public call, and for health units, it costs around 1,000 to 2,000 reais, a very good prosthesis. Many times what we have around is like, not a good work. I create processes, the same processes to to everyone. I don't have this customization. There are, and I'm not mentioning them. There are units that say they want 200 próteses, and regardless of the measures, and then I'm gonna try to make them fit into the patients, and this is, this exists, and they ask for standard wheelchairs, and they don't understand what criteria are involved in assessing the wheelchairs before you buying them. It's not a problem coming from the ministry, the public ministry. It's our problem because we don't know how to manage. People say, and I won't mention names here, but there are places where, they're like assembling lines. I'm gonna buy for you that are coming from SUS. I can only give you this type of próteses. But if you are private, inside the same unit, I'm gonna give you a different próteses because you're gonna pay for it. There's no need to make this such differentiation. If you have a well-structured service from both sides, no patients deserve to be treated like these. I can use a simple prosthesis in an old woman because she wants it for aesthetical purposes. But if I have other people, I don't know, an athlete that I can, develop his or her potential, I have to take into account all the context of and the life of that patient. It's not true to say that we will have, that we will lose money. We lose money, we create damages when we don't assist properly the patient, because you have a patient that arrive with a condition, we don't treat the patient well, and 1 year after, he's gonna come back with another issue, with another condition. He was not treated well on the first time and won't be treated well on the second time. This is a loss. This is to waste money. If I don't buy a good equipment for the unit because I don't have money, I have a way to find this money. This is our biggest challenge, you know. It's a big challenge, make so that I can take all the technology to the public system, to the private system, okay, but I won't be, assisting the biggest part of the population through the private sector. I have to group education, health, and sport together. I cannot leave this triplet aside. And it won't work if we don't work together. I need this. This is the biggest challenge that we have. It's not impossible, but we need more skilled managers. And it's not possible to do it if we don't make research too. We need research on this. We have to bring research institutes together in these centers working with us to promote changes. I'm gonna, be here for questions, of course, if you want. It's just, fast introduction, but we could stay here 2 days. We're discussing about it. Thank you.
Bom, está avançado da hora e a pedido da presidência do Congresso.
It's for questions about restrictions from the next harassment. I'm not going to have a period of discussion because I ask you to talk to the professor so you take any doubts you may have from the presentation. So I will end now the table So came here on the front so I can do the photography from the group and
Oi, agora a gente vai ter um intervalozinho para o nosso coffee break.
Hello, now we have our coffee break until 10:40, and I ask you to please return at 10:40 not to cause more delay.
Vamos lá, pessoal. Mais uma
Let's go, guys. Once again, good morning, everyone. I would like to call Professor Dr. Cláudia Henrique da Costa to lecture on innovation in the management of co-PD.
Good morning, everyone. It's a great pleasure to be here. I'd like to thank the Nubia especially for organizing this Congress. So nice that we could gather here. We could stay talking on the coffee break, eating nice food, having a nice talk. So let's go. I will say about the COPD. I won't say about the vibratory platform. So I'm going to talk about some news relations to the theme. The COPD, the third cause of mortality on Brazil, losing only for the heart disease and vascular disease is a great income of mortality, and underdiagnosed patients is a bunch of epidemiological studies. You see this darker strings here. You see the public studies. You see that most of the patients do not know they have COPD. They have though the hat is this one on light blue, so you see there's a great tendency so the patient don't know they have the disease. So why is underdiagnosed? The patients don't know and they aren't diagnosed correctly. So between this is the COPD on patients on non-tabagism patients, because they think that smokers had this disease, but not all patients are smokers. So you have around 20 to 40% of patients never have smoked because they are exposed to other types of smoke. And half of the women have COPD, and it's not old man, because you only think about old man has smokes, so you don't know where this COPD starts, because the disease came and is going to manifest, but in what age? So let's not talk about it. And the other question is the fact that we need spirometry to do the diagnosis of the patient. So I need this patient to do this test and have the FEV1 VVS post PD most who's more than 0.7. And the concept is arriving is the lung function, because we should think on these things, how much the lung grow, because it's a part of the body as it all. So we are born on the belly of our mom, so it's a gestation who is cool. You do not use any drugs. It is a healthy gestation, so the kid should take into the intrauterus live, have a healthy development of the lungs, and then you have a curve of lung function around to 20 years. The woman goes around to 20 and men go to 22, 24 years. But I think that everyone here stays up to the long growth. So from this point, you stay on this plateau from the longest time we could, keeping the normal maximum lung function. So the person who couldn't achieve this lung function, they started their life with a deficit. So they have a living with any questions they may have. So we have here long of curves of growing of the lung function. And when COPD starts, it's established in which period of the life of the patients you could say they have COPD. Now the diagnosis is biometric. So the disease started? Probably not, because you have the diagnosis at that moment. But where did it start? When I should act more preventively the diagnosis and the disease. This diagram is from 70s, and this time they believe this, and I tell you this history is wrong. Do not take pictures because it's totally wrong. Because they think you develop the lung up to 100%, and then you have the smokers have a decrease and the others do not have a decrease. And it's not like this, because like that, the history of the lung function, it starts on the pregnancy, and you see in this birth the heredity from their life. You can take picture of this because this is right. So this is the whole scenery of the environment you are insert side our their life or environment where we live, where we work. It influences the development of the COPD. So it's possible, really possible. This is the functional health scheme we have. We have some risk factors and genetic factors, and we're going to start on the small dysfunctions, and only later is going to have this spirometry, and then you could diagnosis on COPD. But you have a glitch before that it's not normal, but we're not doing a diagnosis there, and maybe you could call an early COPD. So what is this early COPD? How we could get to the early COPD, since we say the spirometric it's not the case. So what we have in scenery is this: the most of the patients get us to the COPD, not just initial but advanced one. This is a stage of the patients that more than half of the patients are on the late stage of the disease. It's what we see on our hospitals. We're not taking the patients on the early stages. You take it on a advanced stage, and this is a scenery that is difficult to deal with. And look at this study here, that they were based on COPD gene data. It is a big database. We have numbers of measurements from tomography, spirometry from patients who have COPD, how do some following on cancer. Big data we had. They take the gold zero one with more than 4,000 patients, and they call patients who have the relation if FIV1 and FIVS 0.7, and FIV1 above 80% patients who have a normal spirometry. And they analyze spirometry, CT scan, the walking, and you have some data. So just to start, you have the younger ones. You have person with more than 45 years. So these patients are the young ones. And there's person with like this. You have a lot of lesion, clear lesions. There's no normal tomography. Is scale dyspnea of MRC TP3. There are some patients who doesn't follow the COPD diagnosis but has dyspnea and tomography. So what do we do with them? Maybe we're losing opportunity to a diagnosis on the beginning, where you have the normal spirometry, because we know that the COPD is have a lung function decline in the early stages of the disease, and we are living to recognize this. And this study is really interesting with almost 3,000 patients. You take the active smokers or former smokers and the control group that never smoked before. And they after the cat they have the CPO assessment test, this questionnaire from COPD. So just to remember you who had this punctuation here, above 10 is equal to 0 from 40, but above 10 is symptomatic on COPD. And these patients have a gap about less than 10, and others had a catch outreach. But you have the patients here in the middle, patients who are smoker or from a smoker who have normal spirometry, doesn't fulfill the criteria of COPD, but you see the half of them have a altered cat, so the half of that do not have. So this group, they need antibiotics, corticoids, they are being treated with a lot of things but not having COPD. And these patients go to the UPA, go to the hospitals with respiratory issues, and there is the difference of the concepts of COPD: mild, exposure to risk factors. There's a relation to FIV and FIV at C above 0.7, but have the FIV above 80% and mild symptoms. But what would be the difference, the mild from the early? It's the early disease, the young patients who smoke less and have a relation FIV a little more than 70%, tomography with some abnormalities, and they started to decline the lung function, like workers from the factories. They start to have a decline of the lung function. They should have stopped being exposed to these risk factors, and this is the new goal, but its purpose to look for this and work with this new spirometry. In these are emerging a lot of studies using the AI, especially to analyze the CTs, so we could determine which one are the modification, the early modification that could signalize me to a COPD diagnosis that could have done without the spirometry. We didn't get there, but we this have a big impact in our life, because from the diagnosis, from the detection of early disease, I could intervene the most effective way to, for example, to say to the patient, you have a disease, you should stop smoking, instead of saying you should not stop because you might have a disease in the future. It's a different approach. So we could, based on this, have more solid information to guide health habits and access to better information. And of course, if you needed the treatment, because in some cases you might need the medicine to tend to these patients. And bringing here what I think that there's a lot of physical therapists here in this room, the decrease of physical activity in COPD, it also occurs to patients on the early stage. So it's fundamental to see that these patients could have an action right on the beginning, because we know that intervention with rehabilitation could be real effective in patients and have a drop from these functions on the sleep, on the dyspnea. So the message I could leave for you is we do not know when COPD starts. The genetics and environmental factors contribute to risk of COPD. It's what we believe. And the current diagnosis requires spirometry, so it could left to ask it, but it's possible in the next future the AI could facilitate an early diagnosis with a CT. We are already talking about it on Congress of Pneumology, and appropriate treatment only start after diagnosis. So the early diagnosis is really important. Thank you.
Well, due to familiar issue with some family of someone, we're gonna start the discussion of this particular lecture right now, and then we're gonna move on.
Muito obrigado pela sua apresentação.
Thank you for your presentation. I really liked
Mostra claramente que
liked your slides because it's important to look to the POC, but also problems in life cycle, and the psychosocial model has been criticized at any years, and we've been talking about development in life cycle. And my questions in the sense of if you have been using it in the public health, and what's the percentage of people that need programs of respiratory rehabilitation. I don't know if you have data, it's just that I'm curious because the percentage is very low, and I would like to know how it works in Brazil. I don't have precise data, but we don't do diagnosis. It's just 30% of patients that end up with us, and part of them will arrive to the public system, and a smaller part will arrive to the pneumology or the family doctor, the primary doctor, to be treated, and just a very small percentage will arrive to rehabilitation. Few are the services and units that provide long rehabilitation, so it's something rare. In Portuguese, non-considering only COPD, but less than 3% of the population have access to this type of rehabilitation. Ela não está falando no microfone, não é possível ouvir. She's not speaking in the microphone. We cannot hear her. Part of the doctors in pneumology, children will be referred to more frequently to the public system regarding respiratory physiotherapy, more than adults. This is good news. Yes, I saw it in Jacarepaguá neighborhood. I observed this, and I've been seeing it in several family health units, specifically in Jacarepaguá. They have been working on it. You work with children, right? No, no. I'm specialized in intense care, because I was going to ask you something that was related to the use of electronic cigarette among the youngsters. I can answer you. You have to observe it and research on it. I live with this young population, friends of my son, of my nephew, and the level of usage of electronic cigarette is more than 80%. They stop using the traditional cigarette and start the electronic one. They are in the party, maybe, having fun. And they start, feeling bad, and you have to provide the first aid to them. And they start to breathe again and go back to the electronic cigarette. In Rio, this is the reality. You have a lot of suppliers in city center and in the peripheral neighborhoods. Thank you for your answer. Very well. Let's make the official picture. and the diploma.
Não, é a Carol da palestra que vai. Não, não, você, é a Carol que vai dar palestra no lugar do Rogério. Cadê o. Na lembrancinha dela? Obrigada, meu amor.
Bem, dando continuidade, então,
So
agradeço.
moving on, we thank Dr. Claudia for the brilliant lecture. I would like to invite for the next lecture Professor Dr. Alessandro dos Santos Pin, my colleague, that will talk about effects of systemic vibratory therapy on the symptoms of Parkinson's disease.
Bom dia.
Good morning. How are you? I'm gonna try to stay here on this side because I feel secure in this position here. I like to move, but let's go. I brought today some food for thought about the use of vibratory platform for Parkinson's disease, and my specialty, my academic specialization is neurofunctional physiotherapy, and I'm starting to work specifically with Parkinson's due to personal issues because this disease was the cause of my father's death. So I have some feelings towards it, and that's why I started to research on it too. I won't take long in giving you some concepts because we have already had during this Congress other colleagues that also talked about it in details. But I will just give you a general context for us to arrive to our main point. And I want to remind you that Parkinson's is characterized by degeneration of the substantia nigra, which is responsible for producing dopamine. Dopamine will participate at controlling the voluntary motor control. And in short, it will work, let's say in simple terms, in antagonically with respect to acetylcholine, which will do this transmission process for voluntary control. In the absence of dopamine, acetylcholine will increase neuromuscular functions in such a way that people will lose control of their movements and will start to observe some symptoms, especially the basic one, which is rest tremor. Basically, Parkinson's symptoms are moderate, and I say basically because as it evolves, we will observe other organic symptoms, and in the advanced phase, some neurologic symptoms, behavioral symptoms, memory failing, when the pathology will be in its advanced phase or final phase, let's say. The main symptoms are tremor, and the main characteristic is the rest tremor. It's a bit different because we have the essential tremor whose functioning is totally different. It's the opposite. The essential tremor will increase in rest and is characterized by some neurologic conditions, some peripheral nervous conditions like diabetic conditions, diabetic consequences. And when you are in doubt and you don't know if this tremor comes from resting situations or if it's an essential tremor, the doctor usually prescribes dopamine and verifies if it will improve. If it does improve, it means it's Parkinson. You have rigidity, which is followed by tremor, and this rigidity will break down into other symptoms. We have brachinesia that will cause the change in posture and balance in this patient, right? And the patient will have this very characteristic posture. It's visible. He will try to walk with head slow, heads down, curved, with a very slow gait, characterized by subtle knee flexion, and in some studies we call it Parkinsonian gait. And as it evolves, the patient with his or her cognitive deficits, it loses the gait. Gait starts to decrease, and the patient will take longer to start the movement and will take longer to have a reaction in terms of gait. And when I was supervising my students, if you give your patient a command, don't press, put pressure. Wait for him to start a walk in his time, and then give the command for stopping. For him or her to stop walking, because if you don't give the command, this patient won't stop, and it may cause an accident. This is the motor side of it. But as the sickness, the deep condition involves, we have problems in voice and swallowing, and this is part of the loss of mobility and the problems in muscles that control the vocal cords. This patient will start to have a lot of reflux. We'll slow down the speaking. We'll start to have organic problems, especially in digestive tract. We'll probably have issues and conditions when urinating. And finally, it will show cognitive changes, not only cognitive changes per se, but also alterations in memory. And it's pretty common that they will show depression, severe depression, because Parkinson's disease has this variable, can vary in time in terms of period of evolution, and until the medium phase, the patient will be conscious of the modifications and the changes. This may cause depression. Even if the patient is old, this patient will be impacted in his or her lifestyle, because the patient will start to be, of course, dependent, and this could cause depression. And now I'm start to talk a little bit about whole body vibration. I will also give you a context and a background about whole body and the specificities the main applications for Parkinson and other conditions. Historically, WBV studies started when we had when we were sending astronauts to space, trying to find a way to minimize the muscle skeletal effects in astronauts when they return to Earth. If you have more than 20 years old, if you are more than 20 years old, older, you might remember, those astronauts in wheelchairs going through a lot of physiotherapy to regain mobility, and they found out that using the vibratory platform um, pre and post program will decrease the period needed for recovery. And this was brought to other patients because we found out that besides maintaining the bones, this technique would recover the muscles and preserve the muscles. Talking about vibrations in human body, we're gonna work with external sensory stimuli with orthostatic position and static or dynamic position. Working with WBV not only will be involving a static position, but, and this is very important for the patient, we will be able to adapt exercises coupled with the whole body vibration. And this will bring a series of benefits, such as less fatigue. It the application is short in terms of duration. Sometimes traditional therapy takes 5 times longer, takes 5 times more time. It increases muscle toning and also increases the ROM, the range of motion. And I'm going to call the attention particularly to 2 beneficial consequences: the posture and the gait and the balance. And why these 2 effects? Because usually these are the fields that are most impacted by Parkinson. Here we have a series of works regarding these systems: musculoskeletal and articular and neuro. And we're going to be working also in our cutaneous receptors that will be working on the gait and balance. Here we have the machine, the platform. This platform is simpler, but that's the one we use in Goiás at the Unicerrado University. Now we have 2 actually for research and treatment. Now we're gonna arrive to my point. What does the evidence say about WBV and Parkinson disease? And I'm gonna just say something to you. I was surprised when I started researching. I got these data from PubMed as well. It's updated. I got them yesterday from at PubMed platform from 2006 to 2024. We only have 20 articles found in PubMed using these keywords: WBV and Parkinson disease. It's really few material. And see, I don't know if you can notice here this gap that we can see here from 2016 until 2019. There were no publications about it. And we didn't have so many. Now we start to see numbers increasing for these publications, but still it's not significant. Then I started to see what we had published. This is a very old article from 2008. Double BV was compared to conventional physiotherapy treatments. The 15 sessions during 3 weeks were performed. The protocol used in this experiment is nowadays that is approved and used by other papers, other experiments. It offers good results. A frequency of 25 hertz. PTOP was variable here, but in a range that can bring good results, 7 to 14 millimeters. Conventional physiotherapy was used. 2 hours and a half of treatment, of which 30 minutes of exercises working on posture and balance, and this did not change. And what did they found? Both groups showed a significant improvement after the program, but in this case, there was not a big difference between double BV and conventional therapy. Both achieved their goals. Here we didn't have a group working with both therapies coupled. Here we have a review. This is another study. It's a random study, an old one. This study works with a different protocol with a low frequency of 6 hertz, a PTOP of 2 millimeters, and 10 sessions with 5 repetitions of 60 seconds. WBV improved balance and gait, and the test, which is time and go, showed improvement. However, the authors did not consider this improvement significant from a clinical perspective, and there is an observation here, which I even highlighted in bold: methodology quality. Why? Later on, we're going to talk about systematic review. The great critics to the results today is about methodology quality used for these articles, and this article was quoted in a research that I'll show you later on as low quality, as using low quality in terms of methodology. And this will take to some final observations. I'm gonna go back to 2021. This research is about a comparison of the effect of whole body vibration therapy versus conventional therapy and the use of both together. Here, this is a very important information. Now we use it even for other pathologies with which we use WBV. It improved the conditions of these patients. It improved gait, it improved balance, posture, but this improvement wasn't it wasn't more significant if compared to the traditional treatment. Both improved, but the group that used the conventional treatment together with WBV had a more significant improvement. Still, this research was considered of using low methodology quality. And let's keep this information now. This is a systematic review of the potential of WBV in Parkinson's disease, a systematic review using meta-analysis of human and animal studies. The most common protocols were frequency above 20 Hz, PTOP more than 2 millimeters, at least 3 sessions per week, and a therapy time that is bigger than longer than 3 months. WBV itself showed good results in terms of balance, but these gains were not significant with respect to the beginning. However, it was clear that the gains in terms of neurotransmitter systems, growth factors, neurogenesis, synaptic plasticity, and oxidative stress were significant, and this should not be disregarded, although the authors, again, stated that the methodology was of low quality. And this, unfortunately, the majority of the studies regarding meta-analysis show that we have good results with WBV, especially in terms of posture and balance and gait, but the quality of these studies is not the best one. It's not suitable. Here we compared WBV, conventional therapy, and specific drugs. WBV was superior, but not so much. Going towards the end, WBV is a good intervention because neurophysiological parameters are already consolidated as treatment, and many researchers with different pathologies say so, but what we observe, especially in recent researches, is that the effect of WBV is potentialized if coupled with other therapies. So it's better if you use WBV as one tool when treating these patients with Parkinson's, and the main symptoms such as a loss of balance and gait will be improved, but especially we should take care with the quality of our methodology, which is the main critics that are directed to the main studies on WBV for Parkinson's. So to conclude, WBV in Parkinson's can improve motor function, but with a combined therapy. We have limited research in this area with low methodological quality, and it's essential for us to have more high quality research for this increasingly growing population with better response. And I would like Danubia to be here to to give her a message, transmit my message to her, tell her that we should start working together on this. And I thank you all for being here. Thank you for your attention. Congratulations. Congratulations for your presentation. Wonderful. I would like to invite now to present innovative approaches to patient care with metabolic changes, Professor Dr. Rogério Bozignoli.
Good morning, everyone. So good morning, everyone. My name is Maria Caroline. I'm endocrinologist professor. He is Dr. Matos. We are coordinating ambulatory is a prevention fracture hospital, and we doing something more happy, more fun. So I'd like to thank the organizations to we can talk about the subjects we love, the approach in the care of patients with metabolic disorders. So this presentation is going to talk about the bone metabolism. So I will present myself and let's talk about what is osteoporosis. A lot of things people said is demineralization from calcium and vitamin D, but the concept of osteoporosis it doesn't have anything due to demineralization of the bone. It's the results from imbalance. You have the bone being remodeling process where the rate of absorption exceeds the capacity of the bone formation, and there is a balance. You have more bone being reabsorption, and you could not take care of the bone who are being absorbed. And for the while you're bringing this balance, you take a more fragile bone, and you have more fragile bone. And what it is a minimum trauma. Patient fall from his own place and is going to fracture. The person should not fracture in this fall. And what is more common? So I start my presentation. You have some mechanisms we could use to give this diagnosis. You have only this diagram. We have a normal bone, and the bone, when it starts to lose mass, you have a disconnection from this area from the periosteum. You stay thinner and starts to predispose this patient to fracture. And just so you have an idea, the public here is doctors, nutritionists, who is used to ask for bones densitometry, or are you done the see, the densitometry is a conduct definer. We take a decision of exchange a drug, a medicine, or to investigate again the cause of the problem. We usually do for the femur or the spinal cord, and we do believe on this value though, because what we have now in real life, a lot of people had bad exams, so you not treated you properly, and now we have this reality on our environmental. Around 50% of the densitometry on the Rio de Janeiro, there's a problem we could not identify. We analyze the femur, and here on the spine we see 1 to 2.24 osteopenia. If you have 1.4 and 1.2, you have osteoporosis. You have here the results because probably you need to exclude here the L1 and just to analyze the L2. The patient is not being treated because of a bad result. What's the other? So say people, why you exclude L1? Why we exclude L1? There's a basic rule here. that between two vertebrae, if you have a difference of one, the more pedron deviant, we have less 1.0, you have 0.3, and there's more than one, so you need to exclude it. So if the person who took the exam need to know this, so the doctor who see the results of the exam understand it better. So when you talk about the fracture from the bones, it's a risk factor we have here. After you saw a second graphics, here have a bigger risk of fracture from a third decimal from the ulnar, from the bones, and we see we have two graphics later, the risk of fracture and the hip fractures. If you have a low risk, you do not need to treat, but if you have a high risk, you need to institute the treatment according to the age of the patient. You need to choose the best medicine. Something that is interesting, this is a questioning with this patient. What is more important is the age, or you have any history of fracture. So the patient have more than 70 years, or the parents have any fracture before. Is the patient, you need to have all the lights on, because this is probably a patient who is going to have a high risk and needs to be treated. And what's next way we could do the diagnosis of osteoporosis? You have to see the fracture is a fragile diagnosis. You can see the femur, and you know that the geometry you can do the diagnosis of osteoporosis, but there are some limitations. And I have the X-ray, and then you have some limitations. This X-ray here have a vertebra. There's something wrong with it. This is easy to see, and here is also easy. Usually fracture, there's nothing right on the result. There's a vertebral collapse. It's something that we need to change and have the name of fracture, so we have the importance of the disease. So you have the patient to be scared, because you know that after you be in a patient with a lot of vertebral fractures, and there's a doubt here. Radiologists usually do not have a doubt, but there is a fracture or not? Anyone see it? I give you a tip. We need to compare the height or the vertebrae, the height of every third of the vertebra. Anyone see any difference? Yeah, it's the beginning of a fracture, because this is not so easy. You need a treatment of the radiologist. Not all of them can do this. Imagine a radiologist with 500 exams to give a results in a week. They're going to have an eye, it's not going to. So imagine this patient started like this, and probably it wasn't so simple. There was the evolution of it, and it was there and then there. So the first fracture is a prediction of the others, and patient from other years they have others. The vertebra fracture, it's a lesion that happens for the fragile, because there's no symptoms 70% of the cases. It's not common to the patient ask for the fracture. You are asking, you have any? And he said no, but I have osteopenia advanced. Then you ask for X-ray of the spine, and you said no, I never broke it. Didn't have a fracture. And the patient is going to be amazed. How this happened? And the vertebra was so fragile that it's spontaneous because it didn't handle to the life of the patient, and this ended up happening. And other things we can do see is this have a software of TBS to calculate the trabecular bone score. You see a vision on how is the trabecular, it's more connected or disconnected. You have another thing that's interesting because most of the patients they have a fracture, osteopenia, and not an osteoporosis because sometimes the densitometry is the tridimensional, and sometimes you have a bone with density and the other with other density, but with the tubercular all disconnected, so it's more fragile. And other way to analyze its equipment from extreme CT scan. It's the have only 3 on Rio de Janeiro and 1 is on FRJ. So let's start with a little play here. You can see any alteration here in this radiography, and thing is caught your attention.
Alguém quer falar mais alguma coisa?
Anyone wants to say anything? Give it 1, give it 2. So when you look to it, you're going to see some things. The column is center is divided from 2 places. You see the P12, L1 and 2, L3 and 4, and then I go forward. What is Seymour? The ROI is an interesting line. I have the margins here. Technician didn't see this. This is a big error. I could not believe in this value. And take the density of other place, not just the bones. And this. Anyone see a difference here? Yeah, the same thing. The line is here. It needs to follow. In the radio, we see last 3.5 it's the diagnosis and patients doing the medication without the need. And this, anyone can see, it's more difficult. It's the bra that the patient do not take it off. It's the error of the technician to do the exam because needs to say to take off the bra because it appears in the exam. And anyone see this? It's a little difficult. This line moved a little bit. This is a fracture, so it needs to invisibilize into another one. And this is easy. Anyone can see something that caught your attention? Yeah, something blue. Yes, this is a bullet from a firearm. And how it gets to it? So we have some rules. So we can do the densitometry. You need to do the exam always in the same machine. I'm going to do on the lab of Leblon. But a call it only have on Copacabana, so we need to do the same machine because they have different calibration. So how are we going to do evaluation if we do not know? You need to do the same place, the same machine. Or if you go to a place and have two machines, what do I use? You need to use the same, you use the other time. So you need to be able to see everything in the exam. There not must be anything from one side to the other, needs to be center. So there are some parameters we need to look every time. We need to look first the exam, and then you can see if you can believe on the results of the exam or not. You need to fix the bone in the center and do not hide and bone from the exam. And the arms, you see most common error is that this line they should to be entirely process of the radio, so it needs to be on the right place, but people usually do not do this. So give you more example. Anyone see anything wrong here? Remember when I said it should be center? This bone here shouldn't appear in the exam. And can only fit on this place on the image. Anyone see anything here? Something wrong? Remember when I said about densitometry? Between L1, L2, L1 were excluded. It considered from L2 from L4. This is a correct exam. Every time we exclude a variable, we need to see why it was excluded, what influenced it. Is a fracture. So we need to have a picture of the patient to understand why it was excluded. And here, anyone see this? The line should follow the femur. Anyone imagine what should be this? This is a prosthesis. This is silicone on the butt, and the program will try to see. The technician should do, because the second example is that the person tried to do from the other place. It tried to correct the image, but you can't do. You cannot use this bone to do the evaluation of the bone densitometry. You do not use T12. You only do L1 for L4. This is easy again. He considered here, but he could not. In this region, the femur, he touched place he couldn't. This is easy. This exams is the person who gave us the exam like this. We received like this. We could not see the densitometry for this exam. And I think from after this we take to the theme the last 2 minutes of our presentation. So you can understand a little bit what we're going to say. To understand what is the problem from the bone densitometry is the acquisition error, positioning, the results, X-ray, same thing. The radiography is with a fracture on the early stages. So we're going to propose that our group with some histories we have. Why not use the AI so we could give a pattern? So let's train the AI. Who is the patient have a fracture or hasn't? Because it's how we could alert the technician. So say to the doctor there is a fracture. It is important because it changes the history of life of the patient. We start the treatment that way the patient do not have a fracture, or to prevent a fracture in the future. Inside the area of bone metabolism. Let's talk to ChatGPT. What you think is artificial intelligence? What is the what we believe it is they think the same thing. What's the answer? Fracture prediction and osteoporosis risks, AI algorithms to analyze clinical data, image, patient histories, enable early identification risks, and personalization of treatments, and image analysis, deep learning algorithms, the interpreter, radiograph CT scans, and MRI scans to access bone density and microarchitecture, facilitating more accurate diagnosis. Other thing that's really interesting to use AR, and we can see the VR to loosen down surgical surgery. So we could use it, the algorithms of navigations, so we can see it better. We do a little bit with the robot assistant, but we can give it to virtual reality. This is the video. This is the borders of the training of orthopedic surgery. This is goggles to the training of the doctor. He could have also a virtual reality treatment training so they can go to attending a patient next. The AI is not going to help you to take a decision. It's going to help you to the decision taking, to identify the problem, see where it is, because nothing's going to replace the doctor. So I think we finished. Thank you.
Mhm. Wonderful. Questions?
Alguma pergunta?
Any question?
Não? Não, mas tem. Ah, faz favor. Precisa. É online.
Bone densitometry will be performed on the right femur. Why? There is a pattern. It's a convention. We'll ask if you only ask bone densitometry, you do spine, L1 to L4, and right femur, and we assess the whole femur and parts of it. And let's say that there is a hip prosthesis in the right side. Automatically, it will do it to the left side too. Let's say there is a prosthesis on the right side and a stem on the right side. Then we're gonna use our other parts like the arm and the forearm. So the routine is to perform it on the right femur. The exit for the solution when we cannot use these other parts of the body, we can use a non-dominant part. So if you were, you can do it whatever in the right side or the left side. If you are right-handed or left-handed.
Aproveitar e perguntar
Any other question?
para Alessandro.
I would like to ask Dr. Alessandro.
A gente viu a questão da baixa.
We have seen the low quality, low methodological quality for the use of the vibratory platform in Parkinson's.
Só para a situação
Unfortunately, it does not happen only for Parkinson, but in general terms,
projetos
similar projects
privilegiando a qualidade
do not
mais
tend to
a rapidez
use good methodology due to also the deadlines for the publications. So what can we improve in terms of methodology when we use the platform and for Parkinson's? Thank you for your question, Dr. Nivaldo. What we are usually see in terms of critics is that we have many different protocols applied to the participants of our researches. So one important step regarding the platform, the vibratory technique, not only for Parkinson but also to interventions in other groups, is the trying to homogenize the protocols. We have today some parameters that were published, and also WEG has participated in this research, but in specific terms, when it comes to our Congress, Parkinson is not well studied yet, and we have a huge gap in terms of publications. The oldest results show that we didn't have a standard for the protocols. We would only compare VMB with conventional therapy. And when you're talking about conventional therapy, what is it? There isn't a research that shows similarity in when comparing traditional therapy to the other, because for the first, when they were using a therapy, they would use a certain period of time, and then when switching to another therapy, using another period of time, different periods of time, different duration for the sessions, and then eventually incorporating other exercises, and then you would couple the traditional exercises to various other types of exercises. Would that eventually impact final results? And so in the beginning, these protocols were really different, would vary a lot, and now they are more uniform, and quality improved a little bit. And of course, quality was compared to Cochrane Bibliotech. These results were not invented. They are the results of comparisons, and now protocols are more systematic, and now you have to create standards for traditional therapy protocol, and not only for Parkinson but to other situations. You have to uniform protocols, not only for the platform but to comparative therapies, and that would help us improve the quality in our methodology. Just complementing, we always see in publications using whole body vibrations about this difference in protocols, because we never, and this happens because we never know what's the best protocol for a certain specific situation. If I want to improve frequency, maybe using the platform I will achieve it, maybe using another exercise, but we still don't know. We don't have this clear to us. Another issue that is really so related tightly to this methodology issue is that in the beginning people would, be confused regarding some concepts. Protocol was not well positioned in terms of frequency and period of time. So first publications were really lacking these norms and standardization. And then we had House that tried to organize the standardization in terms of publications. And then in time we saw also that this was not being updated. So the proposal that we have, which was the guideline I showed yesterday, offered by this international organization, working with whole body vibration, they offer everything that you have to report in the publication. If you respect those guidelines that they are offering for report in research, if you respect that, you're gonna have a good quality in your methodology. But you still need that these research groups will be able to, follow those guidelines for reporting. So the main problems of these revisions are usually touching four aspects: the blindness of the participation or the participants, all the bias when you divide people in groups, and this of course impacts the trials, and not knowing in particularly these applications. I tend to say that of course they will be, they will face these problems, and we can say also ultimately that the dosage, the final dosage, will be altered in different protocols, of course, because the dosage implies the width, the time of exercise, and the time in rest. All of these parameters are integrated in the process that we call dosimetry, and this also happens to photobiomodulation. It's crucial for achieving results, and sometimes we arrive to conclusions that are wrong, not the ones we wanted. And if you were already expert in that argument, in their issue, you would know already that wouldn't work. And obviously, it didn't work in that conditions because those conditions were generalized, and it complicates matters. And I would invite Rogério Bossignoli now to participate and take the picture with us.
Tudo mais para todos nós, todos nós, por favor.
And to receive these certificates.
Muito bem. Parabéns. Parabéns a todos. Brilhantes palestras, muito bom.
Oi, boa tarde. Vamos.
Hello, good afternoon. So you can stay here because we're gonna distribute the lunch box here now as we did yesterday, because now we have a presentation of two works, one from Germany, another from Taiwan. I will ask Adelaide to help me present them. So we have 1 minute here to do our prize drawing. Please say a number for us to draw here. All right, 56. Are you there, 56? Ariane da Silva Pires, are you there? No. Next. Go on. 23. Alexandre Gonçalves Meirelles.
Vambora. Bora, Alexandre, já passou. Tem mais um, sorteio. Vai lá, mais um número. Bora. 45. André Luiz Bandeira, cadê ele? Tadinho, chama ele lá, tadinho. Tá trabalhando, fazendo certificados. Tadinho. Ó, E aí, aproveitar mais um minutinho aqui só para falar para vocês que de não esquecer do nosso patrocinador ali fora, do Sans Club. Quem quiser fazer adesão hoje.
Please do not forget our sponsor, Sam's Club. If you subscribe today, you're going to get a package of cookies.
Viu, André? Opa, obrigado. Pode ir trazendo. Ele vai começar a distribuir o lunchbox. É um kit, é só de coisas de cicatrização, então tem tudo a ver com o projeto dele. E a menina que foi a primeira trabalha só com isso. Ela ia adorar, só que não tá aqui.
Posso começar? Se calhar não é começar. Vamos ter um almoço diferente hoje. Vamos dar início à palestra satélite.
Let's start our satellite lecture. We're going to have a video with a video about these lectures, and on 12:30 we're going to talk with this the researchers in Taiwan. Let's try to listen to the video. I'm going to ask you to please pass the video, play the video.
Apresentação.
Let's try to take advantage of the presentation, please.
Hello everybody, my name is Jule Heyeis. I'm a PhD student of Jörn Rittweger at the German Aerospace Center in Cologne and also the Children's Hospital of the University Hospital also in Cologne. And I'm very happy to present to you today the first results of my PhD project, which is about the spastic muscles function. Cerebral palsy is the most common disease among children affecting mobility. In rehabilitation centers like the Unireha Cologne, children affected from cerebral palsy start from a very early age to improve their mobility with different therapeutic interventions. A key intervention in the Unireha Rehabilitation Center is the whole body vibration assisted training. During their stay at the facility, the children perform these trainings 3 times a day. Positive effects on activities of daily living have been reported, but little is known on how the vibrational stimulus affects the spastic muscle directly in its contractile behavior. In research exist some well-established measurement procedures to investigate this muscle contraction behavior extensively. Here you can see how such a measurement has been performed on the International Space Station using a dynamometer, electromyography, and ultrasound. During the measurement, the astronaut has to voluntarily contract the plantar flexors of this right leg. Different tests of the measurement protocol demand different kinds of contractions. Back to our little patients. We want to use this measurement principle from aerospace medicine to get insight into the muscle contraction of a spastic muscle, because we want to understand how spastic muscles behave during contractions. So how can such a measurement be performed with disabled children? Is it feasible? And is it accepted by them? Are the data reproducible? These questions we want to answer in our first study. Therefore, we tested 12 participants with and 12 without diagnosed cerebral palsy on 2 days. We reduced the measurement protocol from space research to the essence by testing 3 isometric tasks: the maximum voluntary contraction, the step contraction, in which the participants had to hold a constant submaximal level for 16 seconds on 3 different levels, and the ramp contraction, in which the participants had to constantly increase the force from rest to maximum and back, also within 16 seconds. All tasks were repeated 3 times. To increase the compliance, we created a rocket-style measurement setup. Participants placed their foot on a platform which rested on the force sensor. The axis of rotation of the foot and the plate were aligned. Electromyography was recorded from the tibialis anterior, soleus, and lateral gastrocnemius. A goniometer was attached to register extensive foot motion. Together with the force signal, they were transmitted to the Noraxon system. The force signal was additionally used to control a video game to visualize the 3 tasks. Here you can see a real-life image of the measurement setup. Visualization of the tasks looked like this. For the maximum voluntary contractions, participants were asked to push their front foot down as hard as they can to reach the ISS. For the second task, participants should collect stars that were arranged step-like. They were arranged in a triangular shape for the task 3. 1, the maximum voluntary contraction, was analyzed in regards to the highest achieved MVC out of the 3 trials. Therefore, the mean torque above 90% of the maximum was calculated for each trial. The highest value of the 3 was defined as total MVC. Tasks 2 and 3 were analyzed for 2 performance parameters. Task 3 was therefore divided into the ascending and descending part of the ramp. Steadiness was defined as the standard deviation of the fluctuations. The achieved slope was calculated using regression lines. Here you can see the results of task 1. On the left side, you can see that the CP group achieved significantly lower MVC values in both visits. On the right side, you see the corresponding Blunt-Altman plot with a difference in MVC between visits on the y-axis and the average on the x-axis. The solid line represents the average differences between visits. As you can see, on the average MVC improves by about 0.5 G from visit 1 to visit 2, with comparable distributions in both groups. During step contractions, we see significant group differences in steadiness in both visits. The CP group shows higher fluctuations. However, the Blunt-Altman plot shows a clear trend in the CP group towards a decrease in fluctuations from visit 1 to visit 2. Participants who showed only little fluctuations from beginning could repeat the good performance in visit 2. During ramp contractions, we see similar results. Steadiness differs in both visits for the descending ramp and in visit 1 for the ascending ramp. Again, we see a trend towards an improvement in the Blunt-Altman plots, here and here. But interestingly, we see no significant differences in performance for the ascending ramp during visit 2, showing that CP patients are able to improve even to the level of controls within 2 visits. Based on these results, we will be able to analyze the muscles of children and adolescents with cerebral palsy further in the near future. At first, the comparable performance of the ascending ramp contraction during visit 2 makes a retrospective analysis of the collected EMG and ultrasound signals possible. Secondly, a next study will be conducted at the beginning of 2025, where we apply the feasible ramp contractions to investigate the acute effects of whole body vibration training on the spastic muscle. Finally, I want to thank all scientists involved in this project, and especially all children that participated in this study. Thank you very much for your attention. Hello.
Vamos só aguardar agora aqui uns minutinhos.
Let's wait some minutes as we connect with Taiwan. Oh.
É mesmo.
Hello.
Alô.
Adérito Seixas.
Bom.
Hello, our colleague Adérito Seixas from Portugal. You conduct this presentation with you, okay? And you follow all the schedule that you send to us, okay?
Hello. Thank you for it's feedback. Thank you for being here. We will now start these presentations from the group of Taiwan, so I kindly ask Professor Jingchong Chen to start presenting.
Hello? Can you hear me? Can you hear me?
Yes, yes.
Yeah, we are listening to you. Yeah.
Hello, dear partners of the Mevitih 2024. Good afternoon. For extra section for us. We are a team from the Taiwan Society of Exercise Medicine. It's our pleasure to share with you 5 applied study using whole body vibration. I'm Professor Jingchong Chen, President of the Taiwan Society of Exercise Medicine. First of all, I will share 2 studies to demonstrate the feasibility and the intervention benefits of using whole body vibration as an exercise intervention in elderly patients with heart disease and hemodialysis. Then 2 studies will be presented to illustrate the possible benefits of whole body vibration as an exercise intervention for the community dwelling elderly. Finally, an animal model will be presented to illustrate how whole body vibration can be combined with nutritional supplementation to explore its effect on exercise performance. I hope that we will have the opportunity to officially participate in a future conference and have more in-depth exchange cooperation with you. The topic of the first presentation.
Dear colleague, please continue with your presentation. You can start.
老师你有有看到他几张了。所以等一下应该他就是会给我们这个画面做。我看一下，我刚刚看到几张了。老师你有看到我吗？
没有。
哦，我刚刚有看到几张。所以现在。哦。
Hello, hello, colleagues. Are you listening? Are you listening or not? Are you listening or not? Please open your microphone. Open your microphone. Hello? Hello? Are you listening to me? Hello? Dear colleagues, are you listening to me or not? Okay, it's fine. So let's go to start the presentation. You can follow the template, the sequence that you have suggested, okay? Então, let's go. Please start. Let's start our presentation. Please, feel free.
Yeah, we are not listening to you. Sorry. We are not listening to you. Please open your microphones.
training comprises four static resist exercise: standing, micro squats, toe standing, and lunge. Each exercise is 60 minutes, 60 seconds. Rest for 30 seconds and repeat 3 times. Next. Pre and post-intervention measure involved blood pressure, heart rate, and pulse oximetry, rate pressure product.
有看到画面吗？有看到画面吗？有看到画面吗？有看到画面吗？
没有。
没有进。
还没有上，
有看到了吗？
哦，有看到。好。
It's okay.
好。The topic of the second presentation is effects of whole body vibration on fatigue, physical activity, and the quality of life in elderly hemodialysis patients. Second slide. activity and the decline quality of life and leisure lab quality of life and leisure lab This study aimed to evaluate the impact of the whole body vibration on fatigue, physical activity, and the quality of life among middle-aged and elderly hemodialysis patients. Next slide. A quasi-experimental study involved 43 long-term hemodialysis patients from a medical center in northern Taiwan. The whole body vibration machine and the 4 isometric exercise is shown in these slides. Next slide. Patient was assigned to an experimental group who engaged in 10 minutes of whole body vibration 3 times a week for 8 weeks before hemodialysis, and a control group with 20 patients that receive standard care. And the exercise prescription was shown on this table. And next slide. Safety monitoring of whole body vibration will be conducted before training, during training, and after exercise training. Next slide. Next. Patients' exercise training schedule will according to their dialysis timetable as shown in these slides. It is expected that every patient can exercise for 10 minutes each time, and the exercise training should be complete within 2 hours before the dialysis. Next slide. There were no significant difference in demographic and baseline measurement between 2 groups pre-intervention. Next slide, please. Post-intervention experimental group shows significant improvement in fatigue, physical function, social function, mental health, and the overall quality of life, while the control group experienced a decline of all these functions. Next slide, please. Dialysis patients. This is my presentation. And please give the next presentation.
Okay.
现在该谁？
从义。Dr. Chen, can you see the slide?
Yes. 你还没有换？
还没换吗？这个系统怪怪的。从义，等一下换你可以哦。OK。Okay, go. Tony, can you see the slide? Hello?
The microphone.
Doctor?
Turn on the microphone.
Tony, 麦克风没开吗？聪毅，你没开麦克风。聪毅，你没有开麦克风。聪毅 ，please turn on the The microphone.
右上角，右上角有麦克风。
OK。
开了会影响。
Hello? Okay. So right now it's okay? Okay, so can you see my voice?
Yeah, with a little echo.
Okay. So right now it's okay?
Not so good because so many echo.
Many echo?
Yeah.
That's so. I don't know what. Better. Right now it's better?
It's okay. Better.
Okay. So, hello? Hello?
Yeah, it's okay. You can go.
So right now it's okay?
Yeah, it's better. Yes.
Okay, so in my, I'm sorry. And so is it my turn?
Yes, your turn. Yes.
Okay. Good afternoon, everyone. Thank you for this opportunity to present my study today. So my study title is Effect of the Interventions of the Vertical Vibration, exercise of the upper and the lower limbs and in the pre-muscle stress interventions. And so it's also the echo. Oh, it's okay. So in pre-muscle stress training on the improving daily mobilities in the frail elderly people. So this study explored the potential benefits of the vertical vibration exercise as the pre-stressing intervention of the frail elderly individual. So next page. And as the age population increase globally, frailties and mobility issues in older adults has become a major public health concern. Notably, Taiwan is experiencing the fastest aging population's growth in the world, leading to numerous challenges such as inadequate nutrition, chronic diseases, and functional decline, and increased dementia care needs. So according to the National Development Council in Taiwan, 2024, the prediction data shows that by 2070, the population aged 65 and over is expected to increase by 2.5 million. So this is a severe issue from Taiwan because of demography should present a significant financial burdens on universal health insurance. So in this study, we aim to identify the effective strategies for improving physical functions and eyes in the elderly. So in this study, to investigate whether incorporating the vertical vibrations before the transitional muscle stress training can enhance the daily mobilities for the frail old adults. The groups are particularly vulnerable to mobilization. Next, on the next page. So on the next page, sorry. This page. Okay. Next page. Thank you.
Is page 3, right?
The page 4.
Page 4, okay.
Okay. So our study focused on the frail elderly individuals aged 75 and older with a frailty score of 3 or more points. Our experiment design include 3 groups. The first is control group. Second is a muscle stress training group. The participants underwent isokinetic resistance training just for 60 minutes per day and twice a week over the 12 weeks period at 60 to 70% of the one repetition maximum. And the third group is the muscle stress training and combined with the vibration trainings. So in addition to the same stress training protocol, this group also performed the vertical vibrations exercise for 10 minutes at the frequencies range from the 3 to 12 hertz for 4 weeks before the strength trainings. So during the early adaptation phase, perform 10 minutes on limbs vibration exercise to enhance the muscle fitness, helping weak individuals improve the stress and boost motivations. In the enhanced phase, the vibration trainings will be used as a part of the warm-up. Afterwards, isokinetic resistance training machines will be incorporated for further muscle strength training. To assess the effect of the interventions, we conducted functional fitness tests and gait analysis to measure improvements in the mobility and physical functions. So on the next page. So for now, this project is still working. So we have the preliminary data for the gait analysis. Okay, the next page. So on these pictures, I just only show this gait analysis. So the first in the control group, we did not detect any changes in the control group before and after the follow 1 and the follow 2. So in the muscle training only group, we observed that the hip joint torque and of the elderly, the first decrease, and then in the follow 2 is increased when the workings. So it's an interesting result. Show the muscle transcript with the vibration training. Their hips angle will increase in the both follow 1 and the follow 2 stage. So our findings may offer the new insights to the effective interventions for enhanced daily mobilities and promoting better healthy outcome in the vulnerable populations. So thank you for listening, and that is my presentation. Thank you.
Okay. Next is the Jia Liang. Wait a minute. Can you see the slide?
No, I cannot see the slide.
Okay, see it. Can you see the slide?
Yeah.
Okay.
Okay, it's my turn. So everybody, tonight I will present my study. The title is the effect of a single session of isometrics resistance exercise combined with whole body vibration and blood flow restriction on neurocognitive and biochemical indices in adult. So next slide, please. So with aging, neurocognitive decline, decreased hormone secretion, the loss of skeletal muscle structure and function are observed. So this will be lead to significant functional impairment. So as we know, resistance exercise combined with whole body vibration or blood flow restriction could be effective approaches to improve these problems in older adults. However, until now, the effect of resistance exercise combined with whole body vibration, blood flow restriction, or both on the physiological mechanisms involved in working memory performance have not been thoroughly examined. Therefore, our study aimed to explore the immediate molecular and neurophysiological mechanisms that affect working memory performance following resistance exercise paired with whole body vibration, blood flow restriction, or both in older adults. So next slide, please. So we recruit 51 participants randomly assigned to one of three groups, WBV, BFR, or WBV plus BFR. Before and after an exercise intervention, neurocognitive performance of the delayed matching to sample is one kind of working memory cognitive task, including accuracy rate, reaction time, event-related brain potentials, and the levels of biochemical markers such as insulin-like growth factor 1, norepinephrine, and the brain-derived neurotrophic factors were assessed. So next slide, please. So from this figure, we can see although none of the three exercise interventions significantly facilitated reaction times in older adults, when performing the working memory task, isometric resistance exercise combined with WBV vibration accuracy rates in the working memory congruent condition. In addition, whole body vibration plus blood flow restriction lead to increased accuracy rate in both the working memory congruent and the incongruent conditions. However, there were no significant improvement in reaction time in the 3 groups. This suggests older adults could improve their working memory recall accuracy through acute bursts of isometric resistance exercise when combined with whole body vibration or whole body vibration plus blood flow restriction, with whole body vibration plus blood flow restriction producing more robust effect. Next slide. So with regard to the neurophysiological effect, although P3 latencies in ERP remained largely unchanged, P3 amplitude significantly increased in most conditions and the electrode following the intervention in the whole body vibration plus blood flow restriction group. But in the whole body vibration group, we can see a significant increase in P3 amplitude was observed post-intervention, but only in the congruent condition at the frontal electrode. So this finding suggests that although neither exercise mode, whole body vibration or whole body vibration restriction accelerate cognitive processing speed in older adults performing the working memory task, we can see that both the exercise mode enhanced the attentional resource engagement necessary for various working memory processes. Next slide. So in terms of the biochemical markers, we can see post-exercise IGF-1 and the norepinephrine levels increased significantly in all groups, while VDF levels remained stable. So only changes in norepinephrine levels were strongly correlated with accuracy rate improvement in both the whole body vibration and the whole body vibration plus blood flow restriction groups. So next slide. So in our study, the present findings suggest acute resistance exercise combined with whole body vibration, blood flow restriction, or both may have distinct benefits in preventing neurocognitive decline in older adults. So this is my presentation. Thank you very much.
Okay, thank you.
So I'm the last one, right?
Yes, wait a minute. Yes.
Okay, please. I have asked Professor Kenny Chen to assist me with controlling the playback of the PowerPoint presentation. So please.
Okay, see. Okay.
Yes. Maybe full. Okay. 可以放大一点。谢谢。Thank you. You can control the 可以看右下角有没有可以放大比例 ？Yeah, I can see the slide, but it's smaller than previous one. 比前面的人还要小，可能是右下角，要把它放大一点。
那就不行，那就
OK，
只能这样右下角。
OK， 对，把它拉下来，对对 ，Good, perfect, thank you. Good day, everyone. I'm John Huang from National Taiwan Sports University. Today, I will be presenting our past research on the effects of the whole body vibration, aka WBV training, specifically its impact on exercise performance and health markers in various basic research models. Next, please. Slide 2. Slide 2. Right, thank you. The whole body vibration has garnered increasing research attention with over 2,600 articles published between last 20 years, including over 100 articles just this year. This growing body of literature highlights WBV's potential benefits. Please, next. WBV works by triggering the tonic vibration reflex, which directly activates muscle and stimulates specific muscle groups. This reflex enhances neuromuscular function, making WBV a unique modality in exercise science. Next, please. WBV effectiveness depends on two key parameters, frequency and acceleration. Adjusting these variables allows for targeting stimulation, which can influence the type and the intensity of muscle response. Next. There are two primary WBV systems, lateral, alternative, and the vertical. And lateral systems mimic nature, get movements, while vertical system provides consistent up and down the stimulation to engage muscle group. Next. Right, next. Slide 6. Yes. A Taiwanese university research team showed that 8 weeks of identical acceleration vibration training improved the jumping performance and the body balance, providing foundational data for WBV's benefits. Next. 7. Yeah. Thank you. A US study found that the vibration training improved muscle contractility. Sorry, a previous one. Slide 7. Yes, thank you. A US study found that the vibration training improved the muscle contractility in mice, specifically enhancing strength and relaxation rates without adverse cellular effects, reinforcing WBV's safety and efficacy. Next. Yeah. Slide 8. Thank you. Yes. Article published in the journal PNS, a study demonstrated high-frequency, low-magnitude mechanical signals could inhibit adipogenesis, reducing fat cell formation by affecting stem cell pathways. Thank you. Next. And another study showed WBV's positive effects on bone health, improving osseointegration by promoting osteoblastic activity while reducing osteocalcinogenesis by the ER1 and 2 pathway. Yes. Next. Our labs 20 and 14 study revealed that WBV help control body weight and improve the physical performance in obese mice, suggesting WBV's potential for managing obesity-related issues. Next, please. For our research, yes, next. Yes, thank you. For our research, we used the body green, the BW760 from Taiwan, allowing us to control vibration parameters precisely. Okay, thanks. Next. And the slide 12 and the slide 13, I will show you the experiment design. Our experiment began with inducing obesity in mice through a high-fat diet for 4 weeks, followed by 6 weeks of WBV training. The experimental design shown here illustrates the timeline and the group setup. Thank you. Next. We can jump to the 14, right? Yes, thank you, thank you. Over the 6 weeks training period, we observed weight improvements in the high-intensity WBV group, aka VH, indicating WBV's impact on weight control. Thank you. Next. And for the water and the food intake, right? Next slide. Thank you. During the obesity induction WBV phase, we mentioned we monitor the water and the food intake, noting differences among groups, particularly reduced water consumption in obese groups. And this slide show you the physical appearance. By the experiments and mice in the WBV groups had noticeably reduced fat accumulation compared to the HFD only the group. Next. Yes, 17. Yes, thank you. 17. Yes, this one. WBV significantly enhanced folding grip strength in both WBV groups, showing its positive impact on muscle strengthening. Next. Yes, thank you. After an exercise challenge, fatigue markers like lactate, ammonia, and the creatine kinase level decrease in WBV groups, indicating better recovery and reduced fatigue. Next. WBV reduce epididymal, retroperitoneal, and the perirenal fat pads, showing its effects on fat distribution. Next. Yes, at rest, fasting blood biochemistry in WBV groups showed no adverse effects. In fact, some markers improved, suggesting metabolic benefits. Next. Yes, thank you. WBV also reduced fat accumulation in the liver, helping to prevent fatty liver change induced by high fat diet. Thank you. Next. Next slide just show you our 2015 study published in Metabolism with a high impact factor of 10.8, further confirmed WBV's benefits on physical performance and the physiological function in older mice. Next, please. Yeah. Slide 23 and 24 just show you the experiment design and the grip strengthen. This image illustrates our experiment setup, showing that high frequency WBV improved the grip strengthen, especially in the relative high frequency, aka a VH group. Next, please. Yes, next. Yeah, I've talked there, and then please jump to the 25. Sorry, 25. Yes, thank you. This is the endurance swimming time. The trend analysis show that WBV frequency increased and the swimming endurance time also improved, highlights the WBV's potential to boost the stamina. Next. 23, yeah, 26, right, thank you. WBV, especially in VH group, significantly lower post-exercise blood lactate and ammonia, as well as muscle damage marker creatine kinase, indicating reduced fatigue and muscle stress. Yes, next. All right, thank you. This one is just show you the muscle damage marker CK is decreased in both VL and the VH group. Thank you. And next, yeah. Core temperature and the biochemistry in aging mice, we show WBV increase core temperature and improve several biochemical markers, even in aging mice, showing positive systemic effects. Thank you. Next. Yes. Next one. Thank you. Yeah. Next one, 29. Yeah. 29 just show you some tissue damage markers and the nutritional status indicators also improved by the WBV in aged mice. Yes. Next, please. Yeah. Thank you. The slide 30 and 31 just show you pathological elimination improved by the WBV. Histological elimination showed WBV's benefits on liver, muscle, and kidney tissues in aging mice, especially in preventing sarcopenia-related muscle atrophy. Just show you at the next slide, 31. Yeah. It's just enlarged to show you what is sarcopenia in a sedative control group, the upper panel, and the next, the lower panel is the WBV treated aging mice. Yeah, it's improved. So the less. Next, yeah, 32. Yeah. So make a conclusion. Our original research in 2015 confirmed that WBV can improve physical performance and metabolic function, providing an innovative exercise model for health promotion. Yeah. So next, the last one. I was saying thank you for your attention. I will be happy to answer any questions. Thank you.
Hello, my friends from Taiwan. On behalf of the colleagues on the organizing committee of the...
Wow. Yeah. You did not turn on the microphone. We cannot hear from Brazil.
dear colleagues from Taiwan, it's a pleasure to be with you.
Microphone.
And on behalf of the scientific committee,
No voice,
sir.
You should turn on the microphone.
Yes,
On
sir.
screen. On screen.
Again?
The computer.
Computer.
Dear colleagues from Taiwan, it's a pleasure to
Queridos
be
colegas
with
de
you.
Taiwan, é um
On behalf
prazer
of
estar
the
aqui.
organizing committee
Está com
of
eco,
the
está chegando com
Mevitih
muito eco aqui na
2024,
cabine.
I would like to thank you very much
Nós estamos ouvindo
for
nosso
your
próprio
presentation.
áudio.
And I would like, on behalf of
E
the
eu
name of the
gostaria,
President, Dr.
em
Danubia,
nome do
I would like to very
presidente,
much
da
to
doutora
thank your
Danúbia,
attention. And I would like also
não é possível traduzir,
to
nós
ask
estamos ouvindo a nossa própria voz.
the problems to access the system. Congratulations for the lectures. All the lectures are very important, and the findings that you presented are very important. Sincerely, I hope that
dois, três,
in the future
testando.
you can read the papers about your findings. I would like to thank you, Doctor. Please forgive me the pronunciation. I would like to thank Dr. Jin Jong Chen, who are Dr.
Chega o som
I would like to thank Dr. Tsang Chen. I would like to thank Dr. Chai Yang Tsai and Professor again, I would like very much to thank you for your attention, and I hope in the future you can increase this collaboration. I think that you think, because I suppose that you love the holy body vibration. You have different methods to study the effect of the holy vibration. I hope in the future you can do studies in collaboration. Okay? And again, I would like to finish this section because you must continue with the Congress, but it was a pleasure to be with you. And again, thank you very much for your excellent works and for the opportunity to share with you this space. Okay? And I hope in the next year you can be with us in the Mevitih 2025 here in Brazil, personally. Okay? Thank you again. Thank you very much.
理事长，我们就离开了，是不是？
对，谢谢。那个，
谢谢 Kenny。
对，我们年会的时候请大家来参加报告。
哦，是加良好。OK， 好
，OK， 谢谢。拜拜。
Entre tropeços e mais tropeços, deu tudo certo. Você está de parabéns. Novamente, obrigado. Eu acho que uma falha minha de não ter me comunicado bem com os colegas. Todo mundo sabia que isso ia acontecer, mas faltou a iniciativa de conversar com vocês. Eu já estou perguntando aos colegas como vai ser. Ah, não, depois entra. Não fui tão simples assim, mas o importante é que funcionou.
Doutor, deu tudo certo. Obrigada, doutor. Obrigada. O senhor quer uma aguinha, alguma coisa?
todos. Dando sequência ao nosso congresso, vamos dar início à mesa redonda 9, tá? Inovações Tecnológicas em Distúrbio de Sono e Performance. Convidamos para essa palestra, a primeira palestra, com o tema Novas Tecnologias para Diagnóstico e Terapia de Apneia do Sono, o professor doutor Pedro Lopes de Mello.
Tem uma forma de ficar sem o microfone?
Você tem que gravar, sai lá na gravação. Aqui, ó, laser ponte e para frente e para trás. Isso, tem uma luzinha. Está no meio. Isso. Isso. Tá vendo bem clarinho, tá vendo vermelhinho? Correndo aqui. Isso.
Estou ficando meio cegueta. Aqui. Para frente? Para trás. Ok. Pronto. Acho que deu para ver. Obrigado. Boa tarde a todos. Vamos então dar início a essa sessão do Congresso. Primeiro, eu gostaria de agradecer à comissão organizadora aqui do Congresso pela possibilidade de falar um pouquinho sobre as inovações no diagnóstico e terapia de doenças respiratórias do sono. Meu nome é Pedro Lopes de Mello, como já foi dito. Eu sou professor associado do Instituto de Biologia, no Departamento de Fisiologia da nossa querida UERJ. Minha formação é em engenharia eletrônica, eu sou doutor em engenharia biomédica, na área de fisiologia respiratória e instrumentação biomédica. Eu sou, como muitos pesquisadores aqui da nossa universidade, pesquisador do CNPq nível 1C, pró-cientista e cientista do nosso estado pela FAPERJ. Bem, eu vou dividir essa breve apresentação em 4 tópicos básicos. Primeiro, eu vou começar falando numa introdução sobre o laboratório de instrumentação biomédica. Depois eu vou falar um pouquinho sobre a doença do sono, da apneia do sono, falar um pouquinho sobre os métodos de diagnóstico e terapia.
Diagnostic and therapy during sleep, and also about a field that interests me a lot, which is the diagnostic and therapy during sleep and obstructive sleep apnea detection during wakefulness. And then I'm gonna talk about some conclusions and future perspectives in this field. Talking about the lab a little bit. We are always there, we don't walk so much. We're always closed working, so it's interesting to give you a nice view of what we do. It's an interdisciplinary lab. We have other professionals, biologists, physiotherapists, all of us developing software, hardware, and leading with machine learning. We are dealing also with diagnostics, research, telemonitoring, and treatment of diseases. What's our strategic advantage? Since we control the whole device, the whole structure, we can build systems that will allow us to have more enhanced and dedicated analysis of the measurements we need to that are perfectly suited to our study. All the systems that I will present were developed in our lab since their conception until the use, passing through validation. As we all know, the number of respiratory events during night, which characterizes sleep apnea, is translated by intensity during sleepiness. So it's important for us to develop measurement techniques that are crucial to detect obstructive sleep apnea, identify it not only, but also determine severity and titrating CPAP pressure. And all of you know, but the apnea, the obstructive apnea, has a huge prevalence. Nowadays, around 1 billion people have sleep apnea. So we have a high pressure in terms of development of methodologies for the diagnostic, for the diagnosis of these sickness. And it's increasing because we have an increase in obesity in population. So the increase in sleep apnea will grow as obesity grows in society. We are also going to talk about forced oscillation technique, and it's the application of a low pressure, basically not perceptible, to the respiratory trait of this individual. We're gonna measure the pressure applied, the resulting flow, and obtain, among other parameters, the respiratory obstruction, the respiratory resistance. And we've been using it to use more traditional diseases such as asthma, COPD, sarcoidosis. And the method is so less intrusive that it can be used during sleep without even changing the structure of sleep. We have a device that we connect here, and throughout this device we apply the pressure and we measure the resistance, the respiratory resistance during the sleep, and we are assessing this respiratory resistance, which means the opposing to air passage, and that's what happens in sleep apnea. We are not measuring a direct variable. We are not measuring nasal pressure or thermistors. We are measuring the obstruction directly, and this leads to advantages that I will show you now. In this first study, we detected apnea. This study was performed based on a PhD thesis, and the author is a colleague of ours here in Liège, in the State University. And during this moment, we didn't know how this could operate, and we tried to inquire. And in blue here, this is the aerial flow, and decreases with sleep. Apnea starts, and we see here a frank apnea. The obstruction led to an enhancement in resistance, and the aerial flow is here. So that's what happened during this moment. After that, we have the apnea a little bit, desaturation, and then the person wakes up, hyperventilates, open the aerial trait, the respiratory trait, and then the individual goes back to sleep, and has another apnea event. The first one was an apnea with an obstruction, so we have an obstructive event. Here, down here, we have an aerial flow that is changing, resistance is always changing, revealing apnea, and then resistance is very low here. What happened here? We have here an apnea without other events, and it describes a central event. So with this technology, we can discriminate obstructive apnea and central apnea, which is very important for us to optimize the treatment. Another step of this study encompassed CPAP adjustment. It's a treatment. This is an individual with hypoapnea. We have our peaks, flow limitation, adjusting CPAP in 80 centimeters. The resistance is being reduced here. The flow came back to normal, and the individual is ventilating properly during the sleep. We compared the apnea and hypoapnea index using this innovation, and then after the adjustment using this innovation and the hypoapnea index decreased significantly, and after the adjustment, it was below the values considered as being associated to the condition, to the sickness. Another method that I believe it's very interesting is the tracheal sound analysis. We developed a system similar to this in our lab, and we would like to assess individuals with acromegaly. In this case, this sound sensor is adapted to the neck. We assessed the flow signal and measured both simultaneously. In the beginning, and how does it work? How can a telephone verifies apnea? So when the individual has this area roots open, the flow is laminar. What remind us of physiology. And then the flow is enhanced. It becomes turbulent, and the sound pressure is higher, so that we can identify, and this was a simulated study, we could identify the obstruction with higher pressure levels. This instrument was elaborated, non-invasive analysis, etc. In our study, we've assessed first normal individuals, and with this yellow signal, and the tracheal sound in blue, and then the spectrogram with pressures of low range. In blue the low ones, and in red the higher ones. You can compare this result with this other down below with typical acromegaly. Please notice the sound analysis in red in spectrogram. So we were able to identify alterations in this individual. We performed the analysis throughout the respiratory flow, and for the same value of flow, we observed tracheal sounds that were higher in the individual with acromegaly. We further performed another analysis for the accuracy, and the accuracy was very high. And remember that an accuracy higher than 0.8 is suitable, and higher than 0.9 is very good. So this method is really promising. And these researchers, they used the method during the sleep with interesting results. This is a normal sound for a normal breathing, and this tracheal sound disappears during apnea because you don't have turbulence, you don't have signal. And with hypopnea, you have a high signal. During hypopnea, the flow decreases, turbulence decreases, so that the signal will be reduced but does not disappear. And this is hypoapnea. When the mouth is open, you can identify it here. Notice that the flow sound intensity is identical, and the nasal flow will happen during the inhale and not exhale. So what we have discussed is obstructive sleep apnea during sleep, and this is interesting. But I found it also interesting when we said it during wakefulness, and this is the golden standard for identifying apnea. But it's costly and very hard, not always available. So what we discuss in literature is how can we nowadays obtain methodologies to identify apnea during wakefulness, and this is done during questionnaires. You can try, but literature shows that questionnaires have a low accuracy, so it's important to develop a specific methodology for it. And this was done by the Dr. Musavi's team, analyzing 122 individuals with apnea and without apnea using support vector machine method, and accuracy was very good. And authors conclude that by using anthropometric parameters and tracheosound analysis, this methodology can be very useful to identify apnea during wakefulness. Another method that I consider promising is the negative expiratory pressure technique. We developed some tools during some years aiming to assess asthma, COPD, and aging effects. How does it work? The individual starts to ventilate normally, and in the beginning of respiration, we apply a negative pressure, and by doing so, the individual will have a higher gradient, remembering our physiology studies. He will have a greater gradient, and aerial flow will increase if he won't have any limitation in flow. But if he will have a tendency to collapse, the pharynx will collapse, and instead of having a higher signal, he will have a limitation in the flow. And this analysis can assess the collapsibility of the respiratory trait. We have performed this study before with young people and elderly people, and I think results are relevant. And age is a predictive factor for the predatory factor for our study for apnea. So the individuals show extrathoracic availability and in non-specific index throughout the inhale part of the cycle. With younger population, we did not observe collapsibility, but it was identified in middle age and elderly populations. As age grew, we could observe an increase in collapsibility. And what do we see here? The increase in collapsibility can be identified during wakefulness with this methodology. This study was done in individuals varying in age. This was study performed directly in sleep apnea with some syndromes, moderate apnea, and severe apnea. And in all groups, it was observed higher collapsibility regarding if compared to the control group. And the analysis showed interesting values around 96.6%, 76.9% respectively, and they conclude that this method can be useful to detect airway collapsibility. Of course, that this study needs to be proved. Talking about future perspectives regarding these technologies, as I said before, this traditional PSG is the golden standard for identification for the identification of sleep apnea. But there are studies that showing that only the AH index may not describe the symptoms of the patients during wakefulness. So there is a tendency to develop a more personalized medicine, customized according to the individual. And by seeing these factors and these results, we can also observe a pressure to develop innovation. It's a high pressure to develop new technologies. It's a very promising field, and I'm gonna mention some events here, such as technologies for diagnostic and therapy during sleep, the use of systems to assess the individual at home using telemedicine, virtual medicine, and the use of wearable technology as we discussed in the morning. So we have wearable technologies that can be useful for this field, and also the detection during wakefulness. We have researches for medical imaging techniques or exhale breath analysis. So there is a large amount of studies being done in these fields. I could be talking to you about it during the whole day until tomorrow because we have a lot to discuss. But what I want to say is that us in WERJ, we have the expertise and the technology to develop all of this. And also we have the demand. We are very well positioned to offer a significant contribution to sleep apnea, either during the sleep and also during the wakefulness period. And I'm available for discussion. I'm really interested. And arriving to the conclusion, I think I'm within time. So starting my acknowledgments, I thank all the students of my lab, all the researchers of our university that collaborate to our lab, researchers from other universities and other research centers such as INTO, FIUCRO, CEFET that help us. I thank CNPq, CAPS. Without them, this wouldn't be possible. And I thank you all for your attention. Thank you very much.
Thank you, Professor Pedro. And for our next lecture, I will invite Professor and Dr. Alchemy with the sports and high performance in sports. And there's a healthy limit. Good afternoon, everyone. I miss my boss. Thank you. Anyone here is the area of sports? We have some. The title of my lecture, High Performance Sport, is there a health limit? And I put here my face, and my friend put the university. I think he was more happy because put my face in. I full professor at State University of Rio de Janeiro. I'm professor of football, of soccer. Since I'm athlete and coming from ethic committees, and I also work on the committee, and here in Rio I also work of the control of drugs, do the drug test on the it's a big topic, so I'm going to talk really fast. So see, there's just two figures that really no one's. The Phelps with his amount of medals, and our athlete that came there. Honestly, up to now, I don't know if the person who was there have the adequate way to deal with the situation of leave this person to go through this line if she was walking like that. So we observe it, the peak performance is a high performance of athlete. There's something we need to think about because there's no relation with health. because it's something we really need to think. The exercise, the sport, we think about it, is really healthy, and we need to think it depends on the limit of this exercise. And the question about recovery and resilience and the risk to lesions, the injury risk. And we're going to talk about these questions here on my lecture. What's the limit? Who is taller, who is shorter, who is heavy, the older? There's a limit. This it was going to depend on the sport that this person is going to practice. Closest to the ground is difficult to fall, so how much heavy you are, bigger the chance of you take the other person down. So they have here some anthropometric. We have something that are clearly a lab thing, because we're not going to use this in a club, in a gym. We have in the book stand hydrostatic and DEXA we have here on WERJ, but we do not use it. It's just for research. And we also have the aerostatic weighting, and on gloves we see the also with nutritionists the bioelectrical impedance. We use it a lot, and the skin fold thickness, the traditional way of measurement, and everything that we're talking about, there's to do with limits. And we see this heavier is Stade. He's a French one who was infected for a long time, numbers of years, but in this day he lost for Kokoro, who was 30 kilos lighter than him, and then he got back to win again after. And we have some attributes, the key physical attributes we need to look up: speed, strength, the capacity of lift things, and the endurance. All of this is part of a high peak athlete. And so observe this athlete. So I put a picture of the video, but this is Hulk. Observe that all of them, the ball is going to run this way. There's a faster way to get there, but who is going to get first is Hulk, because he is really potent and fast. You are engineer, my friend? Yeah, gymnastics we said that there's potions, and engineers said must be a little bother because we say the person has a lot of potency, but this athlete is potent because we have really fast and really heavy. It's how you going to look to this potence of these athletes. We have force platforms. We also have isokinetic dynamometers that we can evaluate muscle strength and control movements, and also 3D cameras of electromyography sensors. And here I'm showing you this equipment, the kineo system, and the jumping platform. You see there's a difference between one leg and the other, or there's a muscle weakness, if there's a problem in the balance or in the motor function, there's anything, and we're going to look for it. This is really interesting. I don't know if you saw this 400 meters with barriers on Tokyo 2020, there was something amazing. Our Brazilian got an Olympic record, and he got the bronze medal. It was amazing because 3 athletes had the Olympic record. One was the gold medal, was the worldwide record, and other ones were the Olympic record. Was something amazing. What is the limit? And we go to the endurance testing from cardiopulmonary tests. It's the what I really like to do, what I do with a lot of property, because I do this since the clinical hospital I have on Porto Alegre. And here we see the VO2 max test, the lactate threshold, the identify the point of lactate accumulation in blood, and the heart rate monitoring. And we monitor not just the heart rate, but also blood pressure, cardiogram, if there's any alteration. This is amazing, so we can monitor our athletes. And not just here on the bike and other equipments, but also in other means. And if you put the person to go to the treadmill, you go to the swimming, you see there's a big difference, because I talked to an athlete from a swimmer athlete, and he told me that when I walk with my dog took me, because my environment is the pool, it's not the on the ground. That's why telemetry helps us a lot to do the field test. You do on the soccer athlete, you're going to do with the proper shoes on the grass. It's different than you put it on my lab, because I only have their bike, and you put on a soccer athlete to do tests on the bike it's not adequate. So now I'm going to show you a lot of works from our lab here on WERJ. There's a physiopathiology lab and the exercise sports lab, and there's other detail that's really important for us. Your research on soccer is there's a certain problem, because when you look this as a professional usually we research with the boys and the girls that are younger on the base training. And we did some study with the girls, seeing his movements and the positions and how they work on defense, on the middle ground, or attack, and we could see a lot of details. This is how the material we have here on wedges, so we can do the research and observe his. We do a systematic review, and you look that with us, we get to the key point of my lecture. What is the limit? The limit here is really thin. The athlete has a lot of fatigue. See, I put just picture, but the picture doesn't mean anything, because he could have injury and also fatigue, and then one could have fatigue and also a lesion. Because I need to go faster, so we do this review. Very interesting. What show first? Injuries. So we need to research the injuries. Look at that. With young soccer athletes in the U17 and 20 categories of professional soccer club, you observe that all of them research the injury of these young players, and all this material showing is from teams with big investment. And we also can see this on the Olympic Committee, we can see it was the first group that could assume it. On the last two Olympics, we could find protocols so the judo athletes could prevent some injuries. It's not the trauma ones, it's the one that came from the training. And here on the running with arrest, and then I'm not going to talk about biomechanics because and we have specific tasks, and I also talk about it then before, and the GPS that I told you. And look here, the mechanical metabolic stress that takes the muscle injury process, and the increase of lactate dehydrogenase, and how you could detect the creatine kinase is elevated in a normal or abnormal. And other thing that we use a lot is the thermography, that it alone do not say us a lot. Who works with soccer, there's a serious problem because the athlete, there is a protocol of doing before and after the training. If he do it before and there's a difference between a limb and the other, he is out of this training. You believe it? Because if the athlete go all night and turn on the air conditioner and direction on the legs, so it could go to the exam and say, no, stay there, you're not going to the train because you might be injured on your thigh. So just you can see that thermography alone doesn't give us the certainty on the diagnosis. So you have the ultrasound, and there is a device of the size of a cell phone. The problem of the ultrasound is that you need to know how to read it. You need to have hours and hours to learning how to read it, this image. Also has difficulty to read the image, but because that's it's a very clear injury. And here in clinic we can do not just on the blood but also on the saliva, because we can, because if you're going to take blood every time, if the person he doesn't want it to do is going to run away from you. The hydration component, you see the difference of the density and absorbance. You can see this is clearer than the other, and all of this, especially the nutrition, you need to do finding so you could do good hydration. This should be individual because it's not all the groups that do it, because some athletes who loses a lot of liquid, like I said, around 5 to 6 kilos he loses per game. So imagine hydration, he needs to be higher than the other athletes. So look here, this chart, everyone here, there's a special bottle to drink water. And sleep, I'm a little bit shy to talk after Pedro because sleep is something we have more difficult to control. So I'm going next because everyone understands it. Because Pedro's talk about sleep, and I think I don't need to talk it more about it. And I have just 5 minutes to talk about it. We do the salivary cortisol and load control. It was systematic review too. Everyone knows what is HIIT. It's a train of high intensity, and it could do to increase the cortisol on chronic and also induced, and means this individual is stressed. And my topic is doping in sports. What three things we need to have for having a doping? Not just three, but it's lack of ethics. The guy trains to go around the rules, and other things to use substances that clearly are to enhance their performance, have a better strength and pass the running. And the other thing is the lack of fair play, because it was like theoretical, because it's not doping, but it's going to hide some results on the doping. And we have some restrictions here: the alcohol, the marijuana and cannabis, local anesthesia, glucocorticoids, and beta blockers. So my athlete who is hypertensive, it could not use the medicine, could not be a hit athlete. No, if you do exam showing that we had his disease and we only need this medicine to be in the same path that the other athletes, yes, you can do this, but you could not enter this after you were finding the doping. You need to enter the paperwork before the doping. You need to have the diagnosis, and not just a paper with a doctor is going to sign there. You need to prove with exams. I need to accelerate now. Stimulants, narcotics, diuretics, peptide hormones. Anabolic agents, stimulants. Sometimes people don't know, but it's just doping in the day of the competition. And the forbidden method is by blood doping, pharmacological, chemical, and physical manipulation of urine. And how I do this, let me show you how. You know what it is? You inject the urine here, and then you put a rectum ample, and when you're going to urinate, instead, it's not right that you relax your rectum. Okay, I'm going too faster. It's because I talk so loud. It's better now, my sound? It's because I was a singer in my previous life, so I could not be. The big innovations and topping the biological passport. What it is, this is the analysis you have of the athlete for a year before, the gene doping detection, and the AI-powered analysis. Every lecture here is going to end talking about AI, but it's this. And I show you the methodological module. There's only numbers. No one knows which individual is doing their test. And there's a hormone and estrogen module, because you can choose. You want the number, it opens the bottle. You can do it on the place you want. There is no mirror. Here you put it, the urine on your bottle. Then after is going to put the proof against proof. What is the tendency? Suspension of control, anti-doping drugs. What is the other alternative? Let's do a games only by doping athletes. If you want to talk a person who was doing doping, he's going to not have a fair play. So this is my. And because of 12 and 10 minutes, it doesn't throw away your life. Thank you.
Mm-mm. Hum? Uhum.
Professora, vamos só fazer uma troca aqui.
Oi? Ah, é? Vai mudar? Por quê?
Chegando pro final ainda chega.
Bom,
Well, so before moving on in our schedule, I'd like to give you an information so that you please speak close to the mic because we are broadcasting it. Moving on to in our round table, we have Dr. Cristiane Bahia, who will lecture on precision medicine in the assessment of excessive daytime sleepiness. First of all, good afternoon, everyone. I would ask you to please let me sit down because I'm so tired just by seeing you, presenting about so many themes. I'm going to talk about this theme that was my PhD thesis. Actually, I am from UP. That is this research institution on sleep and sleepiness. And in UERJ, we also have a whole set of structure that allows us to study the sleep. And I recognize the importance of having more accessible methods because we have a huge population. Brazil is really heterogeneous, but we are in the reference center and we're talking about the most recent technologies regarding precision under these conditions. This is a first introduction about precision medicine, which is personalized, it's customized. You have to gather all the information you can about the patient to understand how that sickness, that condition works. And we use everything, biomarkers, genetic tests, wearables that were mentioned before to create health trackers. And that's it. We're having a shift in paradigm. First, we're coming out of one size fits all medicine to a customized medicine. I don't know if you can play the video. It is in English. I could not translate it, but I'm gonna just go talking about some things. It's so cute talking about precision medicine. I think we can understand better the concept. It's going to talk about asthma, for instance. It affects 25 million people in the United States, And the first medication is albuterol. But let's think about it. Is it the best medication for everyone? You have to take into account the age, what's the lifestyle, if they have pets, where they work, because it makes huge difference in choosing the suitable treatment. It's the same for all conditions. We cannot base ourselves on obvious symptoms. We can gather and collect the maximum information we can to perform this big data analysis. So we are using health trackers, the wearables, the genetic tests, the microbiota analysis, blood works. All of this will be compiled so that we can understand which are the subgroups within this condition. So maybe the individual that has asthma will respond differently if compared to someone else who has an asthma level B, and we may not need to use albuterol. And so let's talk also, and it's the same for other conditions such as excessive daytime sleepiness. We live in a society that deals with speed. We're always doing something. We work 24/7, and this condition, this excessive sleepiness, affects 15 to 33% of population. And the causes are many: depression, anxiety, sleep deprivation, medications. And due to these common conditions, common causes, the primary conditions regarding sleep are underdiagnosed, undertreated. We estimate that there are between 100 and 200 people in Brazil. And when we talk about the population in Brazil, this is a huge number. We have no official statistics about these conditions. And this is hypersomnia, and we have few data about Black and Latino communities, so that's why it's important to study our population. I'm going to talk about primary hypersomnia, especially some of them, because they have this. They start with influenza. So influenza is a major factor impacting, and narcolepsy. It starts with a viral situation, and then the individual evolves hypersomnia from that. So it's important to compare them with other immunomediated conditions. And we are living this precision medicine era. We are doing medications. We have recently had medications for patients with narcolepsy because they lack a specific neurotransmitter. When we look at primary hypersomnia within the International Classification of Sleep Disorders, we're going to see this group: narcolepsy type 1, narcolepsy type 2, idiopathic, and Klein-Levin. The other ones are due to other disorders, such as some disorders, medication or substance, or psychiatric disorders. We discharge these ones and are going to use the first divisions. Narcolepsy and hypersomnia looks like this. People, if you don't know it, it looks like a tiger, right? But when we get to know and we dig into the condition, we understand that although the fatigue, the sleepiness, you really notice that this is an elephant, it's not a tiger. The basic narcolepsy symptoms, besides sleepiness, awakened sleepiness, we had other symptoms. One of them is the cataplexy, which is the loss of muscular tonus due to an emotion. You have hallucinations, and different from psychiatric hallucinations, it happens close to the sleep moment. So people can hear and feel and see things before sleeping, and sounds like a psychiatric symptom. And sleep paralysis. Sometimes a person is sleeping and suffers this symptoms. The majority of patients are going through the religious situations, because this is religious rituals, because this is not considered a symptom but a paranormal symptom. And fragmented sleep. Sometimes people who not sleep a lot, they are seen as poor people, but sometimes people that sleep with narcolepsy, they sleep a lot, but maybe they don't sleep well and they wake up really tired. And we have a way of questioning and making a screening, which is the Webworth Sleepiness Scale. We gave some daily situations, the daily events, and we asked them what's the probability of them sleeping in these conditions during these situations. When you have a certain punctuation, certain score, it means you have daytime sleepiness, and above 10 we consider it really severe and consider it to be almost a primary hypersomnia. Cataplexy may impact neck and other parts of the body and may lead the patient to fall. And sometimes we have also situations in which the patient will laugh and then recover spontaneously. If you look at the individual after a cataplexy event, he or she seems normal. So sometimes these symptoms are connected to psychiatry and other fields. And this is the fall. This is the, for instance, the fall of the mandible when the child is looking at is watching TV. This is how you can create a diagnosis. Well, we have very strict criteria to identify narcolepsy and idiopathic hypersomnia, because they are really similar, but they are different in some points. The most common hypersomnia is type 1 with cataplexy. And how do you create the diagnosis? You perform a test that is called a multiple latency test, and the patient will be there in the lab during the night and during the day, and we are going to be measuring his propension to sleep. We wake up and then we leave him there, and then we observe him fall asleep and try to assess how long the patient takes to sleep and how many times he starts REM sleep, which means the deep state of sleep. The normal person takes 1.5 hours to achieve REM. In early REM, as you start to sleep, this is not common, whether you lack sleep or you have some sort of condition such as narcolepsy. The problem is that these conditions that are characterized by the international bodies, they are very similar sometimes. We have narcolepsy patients that do not have cataplexy, and they are also type 1. We have idiopathic person that do not have a recovery sleep, and sometimes in idiopathic conditions, the patient may sleep a lot and still wake up very, very tired. So, sometimes the symptoms are not enough for us to establish the conditions and the diseases. And we discovered this molecule, which is a neurotransmitter, the hypocretin, and it was discovered that this neurotransmitter is very low in patients with excessive sleepiness. And when you see that this molecule is very low, probably you have a patient with narcolepsy type 1. And this is to show that things change so much that probably in near future, narcolepsy type 1 will be a synonym of a hypocretin deficiency, and other conditions will change name and will probably be grouped because they don't have this deficiency in hypocretin. And why does it make sense now? Because before, even if patient was type 1, type 2, type 3, the treatment would be the same. But due to hypocretin, molecules based on a hypocretin were developed. Look at this molecule here called orexin. If you have type 1, responds much better to this dose here if compared to patients with type 2 that do not respond in this way. They don't have a good response as type 1, even when you perform the latency test and other tests. You are being precise. You discovered who the patients who present deficiency, lack in that molecule, and you just refill the patient with that molecule. You give the molecule back to the organism. It's a peptide. This is this history. This is a peptide. It was associated to human narcolepsy in 2000 until 2014. In 2014, it received another name, type 1 and type 2, just showing the importance of this molecule as a biomarker. And now we understand why the medicine based in hypocretin makes a difference. Neurons are here in a very small part in the brain, but they spread to other parts of the cortex. And this molecule will affect other symptoms, not only increasing the wakefulness, but also attention, the rewarding system, nutrition. And you are also able to understand the other symptoms because patients feel not motivated, depressed, and you now understand that hypocretin is a hub that receives information, physiologic information, process them, and interact with neurotransmitters, dopamine, acetylcholine, so that these neurotransmitters will be adjusted and will adjust the behavior accordingly. I'm gonna go on faster. I have to show that narcolepsy has an environmental cause. And why is hypocretin low? Because people that are likely to have this came across the influenza virus. And you get a specific virus, and a person with a certain genetic condition, which is the presence of this DQ810602, may develop an autoimmune response, leading to loss of neurons that produce hypocretin. The research developed in Brazil, none of them took into account hypocretin. They were still separating patients the old way, and we were different from the rest of the world because the rest of the world was showing this association in a high level, 98 to 100%, and our studies were around 61, 67%. So maybe narcolepsy in Brazil is different. This was a question that we had, and we studied together with Professor Cristóvão when we assessed not only hypocretin in these patients but also HLA in high resolution, looking for other causes in class 1 and in class 2. And the main goal was to study these patients under the perspective of precision medicine through this perspective and using biomarkers. We've been through several steps, collecting patients, and we needed to perform a research. So we asked help to the association, to a certain association in Brazil. They had several patients. They were able to help us with their patients, and we could have 60 patients that presented the diagnosis for this condition. We performed several tests, latency tests as well with these patients, genetic tests, and we compared these results with the biobank of Redome, which is our pearl. We have more than 5 million donors there, and we could compare with basically everything that we want. So we compare these cases with 5 controls of 7 ethnical groups, which would help us deal with our disparities of colonized country. We have several groups of populations in Brazil, and hypocretin is not, it's a type of exam that is not performed in Brazil. We were able to create this partnership with Clínica Mayo and the University of Stanford, who and a professor of the University of Stanford was the person who described this condition with the hypocretin. And the results showed what was already in literature. Patients with narcolepsy type 1 are different from patients with narcolepsy type 2 regarding many parameters, such as clinical ones, IMC, and it helped us think about, in terms of public health, we won't be able to run a hypocretin test for everyone, but if we can understand who may have a lack of hypocretin, we can look for more accessible tests, and we can define which patients have a lack or are low in hypocretin and try to indicate, for instance, certain types of medicines that are hypocretin based. I ran out of time, but I just want to show you that this study showed that 100% of our patients had DQ-B1-0602, so we are not different from the rest of the world. Our narcolepsy is the same as in literature. Maybe we have more difficulties in mapping phenotypes, and maybe this presentation is not clear, but when we go to genetics, we have no doubts that this is associated to narcolepsy. I'm going to go fast through this. Only to conclude, these are the arms that we have. They are supporting us in this research. This is a congress about mechanical vibration. So we work with 11P lab, working with a wearable for patients with narcolepsy and using mechanical vibration as a model. These patients cannot perform exercises. They have the risk of cataplexy and the risk of falling, so they can do these exercises sitting down. And we are measuring all these sleepiness indexes using this device. These are our posters. You can visit them later. And this is a little bit of our participative experience. Anna, the president of our association, is here. We have an empowered patient that is there participating at the congresses, at the lecturers, that is there participating actively in the research. And to conclude, that's it, our team.
Muito obrigado. Muito obrigado, professora Cristiane.
Thank you, Professor Cristiane. So, continuing, we are inviting Adriani, and he's going to have a lecture about technological innovations in analysis, in human movement analysis. I'd like to first thank the invitation. I'll start presenting myself. Professor Roberto, I also put my photo and not my institution. I was there on URCA, I don't know if you know it, it's very beautiful. I'm professor from physical education from the armies, and my formations, I doctor biomedical engineering, and I'm physical therapy by and my so I'm going to talk about the motion analysis. When we think about motion analysis, is it the kinematic movement? I don't know if you know it. There are some reflexive markers. They're going to do the collective gait analysis. It's not necessarily a routine on a clinical practice. We do the qualitative analysis only, and we look how they walk, and we do a description because it's always important. But if you want a more specific analysis, what this patient's developing, so I need a quantitative analysis, like a three-dimensional gait analysis. We have these cameras, video cameras, and the markers, the two platforms, and also the myography. It's a complete analysis. So how are you going to talk about my topics is the optical systems, some inertial sensors, and what I think is the future, especially I think on the clinica, is what you talk about more class is the analysis of the gait only using the cell phone. And this is a classic analysis, a gold pattern, gold standard we have. It's a kit from a project we have on our lab. You can look, it has a reflective marker inside a biomechanical model, and we see there on the computer this markers. And what's the idea of this system? We built this biomechanical model, and it will be able to determine, to estimate, articulate the center from the hips, the knees, and I could have the analysis from the whole body. And this three-dimensional gait analysis, they are really expensive, hard to use, and we need specialized professionals to do the gathering of the data So we need to have the knowledge of the system and the biomechanical so you can extract all the information that the system could give us. And I'm showing you the clinical gate report. I don't know if you ever had contact with patients with neurological disorder. It's common to see, especially in big centers like São Paulo. They do every day, like on Einstein Hospital, and I discovered that they have the waiting line to do this report. So the doctor decided to do if he's going to do the surgery on the patient. I don't know if you can see it, but here on gray it's the normal standard, and I'm going to look what it's outside the standard. And the interesting things that worldwide, when I look to the red lines, I'm look on the lower limbs on the right, and other countries the blue is going to be the left one, and other countries is going to be the right one. And this is just to show the hip inflection, and you see that the gray go up to the end down, and see all both right and left, they're not going all the way down. And how I do the other movements, it has flexion, inflection. You need to see the proud gait. It's the patients with brain paralysis that you see. There depends the lab, which equipment you had, what type of information. Anyway, all the variables we had to look to velocity, cadence. And why is this important? I'm going to show you some cases that we study inside a project. For example, this is my student who is studying early Parkinson, person who had diagnosis before 50 years, and the late Parkinson with people with more than 50. And we want to understand the standard between these groups, and we compare the results. I'm going to show just two variables so we can study and understand the importance of doing a quantitative gait analysis and to evaluate the gait analysis on the young, who is blue, and the older one is on green. You see that there's a parameter who is extremely important, because you're going to have a general idea of the movement. So there's a numbers of way of analysis. We have an important criteria here to use it. On both early and late Parkinson, they have an average of 56 years on the late one. And the only variable it was more different was the simple standing support we have to the balance I have. You see, the younger group has a better expense time than the later one. And what concerns us is that it was the only variable that it's different from both groups. So imagine with the progression of the disease that the young ones is going to have through the years. And this was one of the tests we did with the UFRJ University, is the gait analysis on patients with Hanseníase. There's a lot of studies that show us patients with footfall, and I never found in the worldwide lab how it is the all patients with leprosy has this characteristic. And some patients, they develop a nervous lesion. They lost from the tibia, motor function, and this is really important to the gait. And just to show you, another variable is important is the angle of the ankle when it touches the ground. And see, with the drop foot, you have the inflection angle compared to the control group who has a more neutral line. And inside this project, it was our orthopedics who did it. He did the surgery, and the idea is doing the transponing the posterior tibia from the drop foot. And if you do the transposition and put part of the tibia to the front, and we wanted to know if this is going to work, if you're going to do as a support from the flexor. If you have a drop foot, it's going to bother you during the gait. So if 5 patients, it was just 5 patients because it was during the pandemics, so I couldn't analyze a lot of people. And this is screen, the control group, and just the ankle movements. And the pink, the darker pink here, is the before the surgery, and in blue you can do a better flexion after the surgery. And we could quantify effectively a surgery treatment. I give you this example, but you can do physical therapy and other treatments. So this is why important to do this evaluation, the quantitative evaluation of the gait. This is a project that I'm really interested in. We are trying to study the gait on kids. And when we think about it with kids, analyzing using the conventional shoes with just rubber, and trying other shoes who are more flexible. And just understand, you put a rubber here on the shoe, it absorbs impact and also helps you to propose the movement of the kids. So since we were back in the day, we do not use shoes, so we evolve with a strengthening foot. And the research we do is that the shoes, and this type of shoes, it works with us like a cervical collar, and if you put it, the muscle starts to be weak. And who study these lesions on the lower limb, you see the foot is known as the core of the foot. You have also on the foot one. And what is the big question? If kids do not use a shoe, doesn't absorb better this movements, it could develop better the gait. So they're going to use for time the more simple shoes, and the other ones are going to use normal sneakers. You're going to see if the foot is going to be strength or is going to be weaker. And you see a side infection if you do not use the rubber shoes. So doing the analysis of movement, you have also another technology that I've seen other studies looking to the camera. And now we have the inertial sensors, and allow us to do this evaluation outside the lab. Wednesday we do work And this is a simple, let's show the video from the company. Of course, there is advertised, so it's pure amazing, but just to understand how we understand the movement, the analysis outside the lab, and most of the times it's fundamental because with a lot of sensors, the movement is not so natural, and the gold standard equipment it's so, and the protection of this equipment is really expensive. And the sensor work like this is a project of my PhD student. Is going to analyze the movement of basketball player. You do not bring the athletes to the lab, you do it on the environment. And there's other project where lead by a head of our lab. He was financed by, you put some sensor here, like on the pelvis, in each limb and the foot, so we can do this as a cheaper way. And from the genetic engineer, and develop the system so we can use it on the clinic. And we can do the system to analyze the results in patients with stroke or paralysis. And you see the doctorship here, students, they see the results and put in a biomechanical software, and you see that it costs just a prototype 483 reais, and when we develop the project it's going to be a little more, but a project is going to do the analysis of the movements being more spread on our mean of physiotherapy. And this other study that I brought you so you can understand the importance of this gait assessment. It's a project from another person, and I think it's always interesting this study because patients of Parkinson, most of the time they forgot to have this, forget to take their pills. So we have the accelerometer and gyroscope, so the gait of the patient it's more smooth, more constant. And when we forgot the pills, velocity is, and the pattern of movement changes. So the cell phone was all the time in their pockets of the patients, and the signs of accelerometers from the key collector were analyzed through a neural network. And this is the pattern with the pills, and this is the pattern without the pills. And then it sent information to the doctor and the patient so we could remember them they should take their pills. So it's like inertial accuracy, so it would be, I thought it was really interesting. So think about the future. What I really believe, because for lab it's really difficult to trespass the gold standard for kinematics, but and I think is the marvelous is the moving to the future, and to obtain through AI to know who are the axes of the hips, the knees, and the shoulders, and to look to the literature. We are going to have 404 articles. It is just a prank I do with my friends. They're on the lab. We film with a GoPro, and they could have with a camera of 2D dimensions. You can have some error with the measurement of the camera, and you see how it recognizes another body. It's a promising analysis. There's a group from Stanford. They created a modeling system. And with the markless, he developed the open cap system. You can go to your computer, open the open cap. It's not an app, it's an online system. You need 2 cell phones. It can only be used on iOS. And you take the image to this app and already send information to the gate movement analysis, and you can study a little bit. You could do this analysis. So this work were validated. So the traditional system is the gold standard. It costs them $70,000. Markers showed it takes an hour and a half to mark all the patient to measurement, and then you have just 2 minutes of the collect the data. Then you need to labeling and modeling, and it's more cheap with this system. You can do the collect the data, and you can compare here the mocap, who is the gold standard, with the error of 4 degrees. Is too little margin of error. And these were the tests we did on the lab. We would take 2 cameras from, it needs to be an iPhone from 2018 or newer, and they process the image, and then they came back to you with the results and analysis of the movement. This is a project we do in the university. We analyze the volleyball players from the Fluminense team, and we wanted to see the prevalence of injury on this athlete, and we saw the drop jump in the when the person fall from the box, and how is how you do the drop, and the athlete to have a previous injury and who have non-previous injury, so have a better or worse pattern of movement. So with this information, we could bring to the team of physical therapists so it can work better the standard the ankle dorsiflexion peak. You know that this big wrist injury is have a previous injury. So we need to quantify this analysis, because without this camera analysis, I could not have the amount of image. So as a message, the quantitative motion analysis is essential for objective essence movement, distinguish between groups, and track rehabilitation progress in clinical and sports settings. And markerless motion analysis using smartphones and digital camera could potentially expand the reach of motion analysis to broader range of healthcare professionals, even though for the ones who do not work with biomechanical analysis, especially so you can see some transverse and axial plans, and to see the movements on your phone is much easier. So our lab on UFRJ, it's a lab just for gait movement analysis. You have the cameras, the new building, and it is my son, because when we have a son we bring it to the work. This is my research group. I'd like to thank you, our group, our team. They are really good to analyze the human movement. our head of the lab, the Professor Luciano Menegal. Thank you.
Thank you, Professor. We invite the lecturers for the discussion. Any questions? Eu tenho muitas.
I will start with Adriana. You have the choice. I can give you the question in Portuguese or in English. You know? If it's in Portuguese, it will be just tudo bom. And in English, I will be happy to ask you. I have several questions, but we will have a time to discuss during the coffee break. Thank you very much for this interesting presentation. What I would like to, we are in the same field. You showed a lot of kinematic variables and also wanted to go with the modelization with SIM and all this kind of software. What I would like to know is, like you know, with the kinematic variables, we have a lot of parameters. And the most important thing is to give the advice to the doctor as fast as possible in the aim to make the good decision with the patient. That means we have a lot of variables. I was wondering if you thought for the kinematic variables to determine some kinematical index that will help you to decide faster.
Thank you for your question. I'll
Yeah.
try to answer in English. My English is not very good, but
No problem.
I'll try.
As my Portuguese.
Well, it's a very good question because in the motion analysis, we have a lot of signals.
Yes.
And we usually use some multivariable analysis to try to find which variable is most important to classify subjects, and maybe sometimes you use principal component analysis because of a good tool to reduce the number of variability of data. And in some works, especially when you publish this data, we use artificial intelligence analysis.
Yeah.
But the point is, if you want this data to the clinical approach, usually what I saw is that they look only the kinematic, not the kinematic, but the waveforms,
the shape,
of
exactly.
the curves.
Yeah.
And sometimes they have some index, like normal index, for gate, Gillette index that use principal component analysis as well. Sometimes you do that. But I think the most important is to prepare clinical people to analyze or to look this data. This is very important.
Okay, thank you very much. And did you start to think about the modelization of the behavior of the patient by using SIM or Life Modeler or something like that?
In the past, when you use BTS, we are not so we didn't know how to do this biomechanical modulation in BTS, then you use OpenSim. But now, as you have Vicon, the plugin is so easy to make the data. And we just, in the UFRJ, some students use OpenSim only if they want to analyze muscle force or contact.
Okay.
Only modulation, but not for kinematic analysis, because it's very easy with Vicon plugin.
Plugin, yes. Thank you very much. You speak very good English.
No, it's what's there. I'm not prepared to speak in English.
Yes.
I'm prepared to speak Portuguese.
For the Portuguese, my friend will give me the help. Just one question. Now I would like to make the connection with the presentation of Rodolphe. No. I would like to know if someone can translate. Thank you very much for the interesting presentation. I would like to know, you showed with the high-level athlete all the physiological approach that we can detect a lot of information about the athlete. I was wondering to know why they don't take the mechanical approach. For example, for football, is the sport where we have 11 players. But for instance, in Europe, we make some mechanical approach to improve, for instance, the jump of the number 5, the number 9, how we can improve what I would like to say is the orientation is the physiological part, but for the mechanical part, how we increase, for example, the jump for the athlete, number 5, number 9, to take the ball, or for the le gardien, the goal. Yes. Yeah. Do you know some orientation in this field about the mechanical approach in different sports as football?
By what you said, I didn't understand exactly. You're talking about jump, but I don't know exactly what you're saying. This is not my job, actually. I don't work with training. I just want one comment for Professor. I was listening to what you said about thermography. If the protocol is done correctly, the athletes cannot, hide it, because they should be at least 10 minutes without contact, without being under air conditioning before the image. If they do it, it's because who is assessing is not taking proper care, and you should take care with it. Yes, but in Brazil, the parking lot is very close to the assessment room. But we're talking about players that, it's not worth it to discuss about them. They are outliners. I'd like to ask you if you know research about comparing these programs that already exist, these apps for our mobiles, they are being widely used, and that they perform the alignment, they use the guidelines, and you have an athlete or a patient to jump a certain height, and you place a mobile phone in a certain position, you can assess something dynamic, things like this, but simple things. What's the level of accuracy when you perform these analyses? Do you have any comparison study comparing to the standard gold? Yes, you do. Firstly, to valve dynamics, some studies perform a biodimensional study. You get a cam, but in the valve dynamics, for instance, it's a three-dimensional change, but it has a good relation with this knee condition that we assess. But the valve dynamics, it's an alteration that encompasses hips and pelvis, and in three-dimensional studies you can assess valve dynamics better, but there are several studies that comparing, because it's simple to clinics. In terms of open cap, we wanted to assess vulvodynamics, and I noticed that in the frontal part, and they were very strange, very awkward. And from what I know from the golden standard, it's always problematic when you do not perform correctly the marks. And so within the system, I don't know if I can rely on this assessments of the frontal plane, because I don't know how the hips will behave, how the pelvis will behave, the rotation. So I am afraid of giving a report, a recommendation that will impact the training, thinking about the frontal plane. I'd rather film the frontal plane and perform the markings like Novia, you mark it. I think this is much better than trying the frontal and transversal plane with these markers. I think they're not reliable yet. There are a lot of comparative literature comparing markers with motion analysis, and it's not still golden standard, but we are far from it, I think. Good afternoon. I study motion, and I work with sports. We were talking about performance, and you were talking about the judo team. How can we adapt it? Because we know that our body adapts to stress very well. So we know, as you said before, about Hulk, that he has a higher performance because he's an athlete like Cristiano Ronaldo. So for us who work with science, that study some patients that have not so high performance, how can we compare then? How can we study then an injury and a fatigue? How can we differentiate both? And how can we measure then for each athlete, for each sport? Or should we have to research on each sport to have a positive result? Well, if I understood what you asked, first you have to do it in the group you are, depending on the sport, and perform a punctual analysis of everyone, create a norm, see what they need, because even in collective sports, and that's the case of Hulk and different from judo because it's an individual sport, you have to know the individual, what are the positive aspects, what can be improved, and what is lacking, which are the deficiencies, and you see what the sport needs, what are the priorities for that sport, and then you will train specifically, develop a specific training for that sport, for that person, and for that sport. That's what you asked? Thank you. I'd like to thank all the lecturers for their participation in our round table, and now we're going to take the picture and give you your certificates.
Puxa o povo lá para mim, vai lá. Tem que ser alguém com voz firme. Hã? Né? Tem que trazer o povo. Culpa da Lana. Tadinha, ela veio chegando, eu culpa da Lana. Eu falei, fica aí, gente, come mais. Tudo bom, meu amor?
Depois você me manda mais fotos.
Tá, assim que ela for me mandando, eu vou te mandando. Porque ele vai já já. É que tá um pouquinho atrasado.
Vou pegar dele também.
Tá?
Você não falou dos livros, né? Dos livros já.
Acabou a parte, eu acho que a gente vai gastar de volta.
Eu vou sair daqui, eu vou direto pro consultório. Tô cheio de não consegui desmarcar. Eu te mandei mensagem pro Jara, acho que o casamento dele fosse hoje. É dezembro.
Eita. Aí você quer que a gente chegue lá que hora?
Não, olha só. Tá tudo reservado. O nome de vocês já está na portaria. Então, eu vou tentar estar lá 8 horas da noite.
Tá bom, tranquilo.
Mas só atrasar um pouquinho. Tá bom?
Então, tranquilo. Aí a gente chega e fala que tá com a reserva do teu nome e tal. Tá. Bom, a gente vai iniciando então, enquanto as pessoas vão retornando aí.
Let's start. Before people came back from the coffee break, I want to start with Dr. Angelique. She's going to have an initiative with startup innovation and entrepreneuring in health. It's a discussion theme. Maybe people doesn't know a lot about it. Who discuss it through your researcher career with a PhD. And we learn how to be researchers when we also taught to be one. We pass forward the information, the summation of the research, and this is very important for the research only purpose, but we're not going to talk just about it. How we transform research and innovation, how we can do this inside our state, our country, and not because I think it's nice or I want it, it's because anyone who is competitive, have good index of could do this. And so we could discuss it and demystify on this innovation and entrepreneurship. For another line, when we're talking about being entrepreneur, people talk about things that it's not entrepreneurship, and this it starts to be a synonym for something that is not. It wasn't created for that. The word entrepreneurship came from innovation. Is when you do something innovative. People are entering the room. So when you do cake, it's not entrepreneuring, it's your work. It do this as a synonym of entrepreneurship, and we do see this on the academy. So people are entering, so I'm going to wait just a minute.
Então, eu sou biomédica, né? Tenho mestrado e doutorado em
So I'm biomedic, and I do a postdoc in this area of innovation on UFRJ agents. Is the Inova UFRJ is a place where every institute generates the brain from it, and you have Inova Wedge that is linked to the of the innovation and technology, and I changed my line of researching. I became a professor from entrepreneurship and intellectual property from the Department of Biology and Biology Science and Health University, and I did enter on the being professor on degrees of science and environmental technology, and I have been a coordinator of the Innova UP. It's inside incubator from the companies on FAPERJ and innovation in micro and small business startup on human health and actions by innovations. And this line of research is my theme. I'm scientist and I guide other students with this focus of management and information. And your research could become innovation, but my research already is an innovation. What do you think it's innovation? Anyone wants to talk about it? Because we have difference between news, discovery, and innovation. We say innovation is something that it's able to do something for other person. When we are in the lab, we are not innovating. We're just sometimes it's a new process, is process innovation, marketing process, and how it do change your look to research. It will become a paper, but also became innovation that changed the life of other people. You want other people on the benchmark to use what you innovation. And I want innovation. I want you to discuss it so you could think in solutions. This is a picture that show discovery on the area of technology and how much of this they are on the lab. They were sponsored by Nobel Prizes, how to generate innovations that were on a daily basis and came in with the discovery of the DNA that generate the insulin discovery, and going to the most recent one is the COVID-19 vaccine, and there is the picture of the most innovative country. It's countries who invested in innovation, research. All of them had investment on education and research. You cannot get out of this triplex. You can see this index innovation, global index innovation we had on 2024. It just came out, and this, like Switzerland, for example, is the most innovative country of the world for 10 years. It's ahead of everyone, like United States, Switzerland, who is on the top. And when you look to the companies, you have more innovative one, and 2021 and 2020, you see on yellow ones are the healthcare companies. Here on 18th position is the Philips, who is not necessarily from health, but he is to health devices and have hearing disabilities, and I use some devices so I could hear better. And Pfizer is on first place is because of the vaccine, but you know that Pfizer made the vaccine or it doesn't. Who did the vaccine was this two researcher who won the 2023 Nobel Prize. That 4 years of research of RNA and research on DNA. You have a lot of patents. The story of Catalin, it was downgraded on the University of Pennsylvania because it could not establish a molecule of RNA who are stable. So he could not publish his work, so they started to do a downgrade to assistant professor. And they were really focused researcher and trying to understand that RNA is much more easy to work than the DNA when we could stabilize this molecule. So when had the Pfizer vaccine, it was Pfizer BioNTech. It's a startup that was created by these two researchers. They're in Germany, and they understand that they had on their hand a research that could became a RNA vaccine for cancer in 2008. And they said the vaccine was made really fast. No, they were made for 30 years. They were put on a bottle and our arms in fast because we had a great demand for it. In 2008, this researcher already think about it to use RNA vaccine for cancer. Then 2019, BioNTech, before the beginning of the pandemics, they put the stock market. And in 2020, they have the biggest revolution of industry is to put that patent from Catalin professor to work. So say this is a pivoting. We change the focus of cancer vaccines, but for COVID-19 vaccines. And now we have Kathleen. It seems that she's my friend, but no, because I talk a lot about it. It seems intimate now, but Kathleen professor is scientific director for BioNTech, so he got retired from the Pennsylvania Academy, and then he won a Nobel Prize, and he's now partner from the BioNTech. CRISPR is the decoding of the DNA. Everyone wants to CRISPR save our lives. A lot of research involving CRISPR, including Brazil, and then we had the discovery of a CRISPR different from as a molecule in fact in 2010 by these two researchers, Jennifer and Manuel. They write this molecule, they describe it in bacterial cells. And then I have the biography of the Jennifer Donor who wanted to read it. I recommend it because it's a great book, but it also talks a lot about the CRISPR with the use that I'm going to talk about it. And when we look about the first patents, they were registered, it was 2010, and before it's just about the process, but it started in 2010 after the article. And who was having this patent? It was the researcher there, the Jennifer Donner, the Emmanuel, and Pasteur Institute in France, and then you have the Broad Institute. You have MIT and Harvard, you have California University, Harvard, you have just a few companies that are putting patents. It's much more the universities. But when you look at these companies, they owned by whom is for Jennifer and Emmanuel because they did the discovery, they won a Nobel Prize, and then they are director and partner with this company, and now they can won an income for that. And now Jennifer works on the American senator. She discussed the use of this CRISPR because it had a lot of genetical institutes, and you can have ethical committee discussions. And here in Brazil, we also have it. And insulin, I think is Gentech was the first startup when they didn't even talk about a startup. It was created by a researcher that discovered the recombinant insulin. The person had the money, he believed it, he invested, he thought it would change the world, and indeed it changed the world. And Gentech was created after the patent of the insulin, and it's not from today this interaction of the public from the private sector to generate innovation. I have two tiers of innovation today: triplex helix, and Brazil understand that triplex helix is the biggest amount of innovation. I'm going to go faster because I have little time. In the example, we have Silicon Valley. I think everyone knows it, right? But Silicon Valley actually begin here on the Gentech, because the dean on Stanford University on 1955, he on the post-war, he understand that which more we invest on research, we have more results because of the atomic bomb. Everyone saw Oppenheimer movie. You saw the investment they had for Oppenheimer. So it started to understand that these students and the researchers could have these. So he donated part of his life so these companies could happen. So Silicon Valley, you can have iPhone and other public investment, but these first ones, like universities, you have NASA, you have various institutes of research, and these startups were born. Even we don't even talk about it. Anyone knows what is a unicorn startup? It's so innovative tech, and when they enter to the market stock, anything new, everything that this health tech done, we already do. Is the development of promisor candidates for application in cancer, medical technology application solution for adaptations in prostheses, orthoses, and other things, operational system to combat cancer, or we work to do it. But our research didn't have this value. Why not? But in Brazil, I can like to give this example of COVID, because Brazil in this index we had, they were in 42, and now we are on 50 position. So we are the 50 innovator country. We are there in the middle, but we are 15th publisher on the world, but our knowledge didn't. Our knowledge didn't generate innovation. We couldn't generate this knowledge into products that give us. And COVID, Brazil is the seventh country who had more published on COVID. Anyone has an article? Me too, because I'm also a researcher. But from 120 patents of vaccine that were on IMP, only 5 are from Brazilians and 1 from company. The other one it's from university. It was not just the vaccine. We had to diagnose, need to import masks. We have the technology, but we do not develop the technology. We have legal marks for innovation, telling that we have two public innovation politics. You have 2 laws of innovation. It's amazing because we are back on the track, but we have laws telling companies they need to innovate, telling people they need to innovate, because when it's competitive country, we didn't tell them to innovate because they know they need it. I'm going a little fast, but our legislation for on Rio, we had from 2022 law a researcher, since it's not a probatory state, on license without income, it could go up to 6 years, but it could have an activity, pay activity from research and innovation and development, or in a company, or to participate in education on a project approved. We can, because the WEG could not let me. We need to have a public innovation public, and WEG understand that this is legal. You need to understand that the politics of innovation needs to be done. Wasn't published yet, but it could have our opinion of it. So numbers of university, FAJ already done this, and the law also have the sharing of lab. I can have in a lab my company, my student have a company, and this company is inside it, and they paid WEG for my lab. In any way happen. It can happen, but it needs to have innovation politics for each institution to do this. And now it's really fast. Innovation in Brazil, deep tech. You have 67% of the startups from deep tech on Southeast, and 55% of that it's on São Paulo. We are in the fourth state on Brazil, have companies of deep tech or biotech companies. Most of them is in niche development. We didn't have the product yet. And 50% is biotech direction for the health. That is our case. Human health and pharmaceutics. We see there's a income here on human health since 2015. The most competitive and to guide us with diagnosis, oncology, and everything we do in our labs is a biotech map we have from startups. We see these in fourth place behind São Paulo, Minas Gerais, Rio Grande do Sul, and Paraná. They have 5 institutions, 5 ICTs, Fiocruz, Biomanguins, Vital Brasil, and we are the 4th state to do innovations on health, human, and biotechnology. There's another book if you wanted to learn about it. How are the Brazilians who are unicorn? We have 15 unicorns. That companies who worth it 15 a billion. I had more things to talk, but my time is ending now. And this is the question that guides us, the CAPS, CNPq start to do from scientists. Your research already generated a job, you receive royalties, and we are start on the back how many quotes you had. So you can say, okay, Renata, but I do not own R$1 to do a company, but FAPESD give you this money. They are trying to create these programs that put money on companies already established, but also on companies from doctors and PhDs, and give scholarships to more money to the company and to the person. This company should be inside a mechanism of innovation. They can be incubator or accelerator. Anyway, most of entrepreneur and doctor, we are from health. One of them is Ryujin is here from UERJ. He is on Nova UP. And we start to structuring this company, in fact, because she is done a test to prostate cancer. Here is Inova UP, who are inside of Predonesto Hospital. We're starting to structuring the room. So if you are a student and do not need to have a company, but you have an innovative idea, want to talk to us to see if it's worth it to do it with your market study if you want, if there's a patent already. I have 5 or 6 demands for nurses that invented things and didn't know they could have a patent for it or to protect their ideas and distribute this in a better way. So we're starting to do this education to amplify, and I'm coming here to be the head of it. So we are starting to create we are focusing a lot of MCTI, MGK, MEC, and trying to have a decrease of research on the superior, because we have more than 3,000 doctors by year, and we could not have all of these students because and my Nobel Prize of 2024 is the RNA doctors, but maybe in 10 years or less, we already had this someone doing the company about this research, or maybe these researchers. So thank you. We can discuss now.
Thank you very much, Professor Renata. Do you have questions to her? No? She gave you food for thought, right? That's what I live for. To make you think and vibrate. So since no one asked, you said you were structuring your work at Inova UP. What are your perspectives after releasing this to all the community? Are you going to give support to... we want to create a health technological park in Rio. We have, ambitions, big ambitions. We don't have a health park. We have a technological park from FJ, focused on oil and gas, and now they are diversifying it. We have something that the law and norms in UERJ do not help us. We have to develop other tools, other regulation tools to have incubators. UERJ's incubators work as an extension project for research. And this is bad because we don't formalize it. And in other places, the incubators have CNPJ. We have 6 in UERJ. But if you think we have some companies, but we have 85 patents and no technology transfer. We are open since last year, and we've been trying to work and structure this health park. And the idea, that's it, transform all of this in a technological park for health to serve the demands at SUS. We created a demand in PR5 because we understood that UERJ does a lot of things, and we want to transform these things in a product to meet the population's demand. If you don't want to sell it, okay, you don't need to sell it. If you want it, okay, but you don't need it. We can do it in a formal way and donate. The Federal University has developed a pacifier for syndrome for babies with Down syndrome, and went to the city hall. The city hall created it, produced it, and distributed to the health centers who take care of children with Down syndrome. And there was no financial exchange. You know, we have now Flash that you all know that yields to USP, to the University of São Paulo, 5 million per year, because and USP can do whatever she wants with this 5 million. Unicamp has 500 patents, I don't know, 100 licenses. This is a financial return in which you can, you know, buy computers, adjust the infrastructure, make renovations in the buildings. Also, the professors can also receive financial support, and we have to see it. Well, excellent. I think our minds are, you know, boiling. But what's innovation? You said about the pacifier, but here at the State University, we don't know where to start. I thought that Inova UP, I thought that someone would be there, you know, doing something really technological. You don't even need to be related to technology. You know, the pacifier is like zero technology. So how do we get to know it? How do we get informed? How do we know that our research can be there? Who do we talk to? What's the path? Inside UERJ's health department, I can help you. We want to do this training, educational part. We're going to start next year with our programs, but especially nurses. How many products are invented and the processes in nursery? We have no idea. I was someone from the surgical department came to me and asked me to be a patrimonial agent, and she's mapping using technology all the devices in the surgical center. And she asked me how I was doing and what now, and we are helping her. So inside PR5 and DUB and the Cabo Frio Hospital, we are structuring this step by step. We are creating an innovation department inside the PR5. The State University, and I'm saying it because you can only have one place, which is neat, that we call Inova UERJ, that is there located close to Bradesco. Yeah, you just go there and schedule a meeting with Professor Brandt. I'm even giving you the name. Professor Brandt and Professor Susanna, who are managing Inova UERJ. And within health, we can, you know, talk, get my contacts and call me. Thank you. There's another question. Sensational and fantastic, but it's just a comment for people to understand. Not all innovation needs to be complex or spectacular or full of, you know, buttons and else. Sometimes they're just simple ideas, and these are even easier to deal with. Giving you one example, we use in a surgical center, we use a skate. It's not a skate, it's a fabric with rods. And this was created by a plastic surgeon to, you know, transport obese patients. These are simple things and are extremely useful and important today, you know, to transport or transfer an obese patient without trauma. The solution does not need to be complex. It has to be efficient. And efficiency, you just go there and give an answer to that demand. We have a probe. I always give this example because it's really incredible. There is a probe created for children. It already existed for the nose, for the face, for the adults, but we didn't have it for children. And a nurse in Laranjeiras developed together with the official probe company a child probe. It's called Diana, and it's sold to everyone. The person who developed this probe did not earn one single how. She became famous, but she didn't get any money because she was happy because she wanted to solve this problem. And if I were you, I would call the Ministry of Health and sue them because and sue the company because all the idea, all the design of the product was done by her. Well, she should get money from all the probes sold. She should have a commission. And this is important to think as an example. These these simple ideas are innovations. They are waiting there for us to be discovered. We want to cure cancer, but until we make it, we're gonna invent things to improve people's lives. Thank you very much. Next time I'm gonna give you more time.
Sempre assim. Eles não investem também, né? Mas é interessante.
Thank you very much. I will be happy to be with you for this.
Não está.
We will start by the first presentation entitled Importance of the Ancient Recovery After Surgery by Prof. Dr. Flavio de Saribero. Please, Flavio.
Presentation. Dr. Flavio de Sá Ribeiro to talk about importance of the enhanced recovery after surgery, ERAS, protocol in patient recovery. Good afternoon, everyone. It's a pleasure, a great pleasure to be here. Flavio de Sá Ribeiro. I'm the director of this unit. It's an immense pleasure to be here. I'm a professor at this university. I've been a professor at the university, the Federal University, master and doctorate programs. I also studied in France. I worked with transplantation, but I am an oncologic surgeon. I work in this field that it's kind of different from the usual. I work with, it's called special oncology of great resections and combined resections. This is what I do and what I specialized in throughout these 36 years of work. And why is it? Why does this issue belong to this Congress and to this discussion? Because my activity cannot exist without the support of all the other colleagues working in health. And recently, we have established a protocol called ERAS. This is a protocol that aims to reducing the time the patient stays in the hospital, regardless of the surgery. And this has started with cardiac surgery, we call the fast track, and it gains space in other modalities, mainly in my field, which is special oncology. What is this for? We think that about ERAS as a process of a post-op process. And here is the special thing. It's a pre-op process. It involves much more what I do before the surgery than what I do after it. After the surgery, this is a direct consequence of what I do before the surgery. So I sometimes play with my students when I comment on the surgeries I do. And I like so much this sculpture of Rodin, which is the door of hell. Usually, if you do not prepare the patient in a proper way, you are inviting this patient to go through this door. A great part of the surgeries I perform that but the potential to transform the post-op in a hell for the patient. So what should we do to avoid that? We use this figure that's part of the hell's door, the thinker. We have to plan, plan, and plan. Whereas this is in a multimodal way, prepare the patient for perioperative care, perioperative, peri, and post-op situations. And you do as to minimize the surgery, the damage potential of the surgery. And the challenges for facing great surgeries: age. The majority of them are more than 60 years old, and none of them have a history of physical activities, exercises, or being athletes. Then I have sarcopenia as a consequence of aging. I have muscle loss, and the muscle for the surgeon, it's the savings account that allow you to spend money and spend that money that you didn't want to. Sarcopenia as a consequence of sickness, and this decreases it. This damages the the patient's situation. Alteration on the respiratory function, malnutrition. So the first thing is the paradigm of time urgency versus adequate, suitable preparation. In Denmark, if a patient is diagnosed as cancer treated surgically and he's not operated in 30 days, you start a criminal process against the doctor. This is the reality in Europe. But also, the European Association of Oncology, they went to the government of Dinamarca to say that in certain situations, you gotta have more than 30 days to look for a suitable preparation of this patient. So you cannot just, use this period of 30 days for all situations. So you have this protocol that through which this patient is treated with emergency. This patient has to be prepared. So this balance between improvement in time for preparation and surgical results, this has to be done with tranquility. Here again, in terms of fragility, for it, which is a bad transition for frailty, but we can use it in a poetic way. The impact of frailty, because of the sum of the pre-existing conditions, enhances complications and the length of stay after the surgeries. Of course, that everyone wants a surgery like this. Everyone wants a surgery like this. Is wonderful. This is fantastic. It looks like the easiest thing in the world. Absolutely the easiest thing in the world. But this is not a reality in Brazil. Cancer is far from this reality far from being this reality in Brazil. Diagnostics, even in private life and public life, diagnostics are in majority done at later stages. Here I have a patient, and I could prepare her in a very suitable way with an ovary cancer, operated with a seat. She had disseminated disease. We have made a cytoreductor procedure to control acid, and then we performed 6 chemotherapy cycles. And during the cycles, she was doing physical activities, exercises, gaining weight and gain mass, muscle. What happened? What was the result? She had an extremely calm post-op, and not always can we get this solution. Can you just click there, please? This is her post-op of a 44-year-old woman. This is the pre. She was doing the same. We operated her. Her histopathological had 2 pages of resection in other conditions. She was under 6 cycles of chemotherapy. Her son is a professor of physical education. He put in her mind a need for exercising. She waited the authorization of her insurance for the surgery, and she was exercising regularly. This is her immediate post-op, showing her recovery and her tolerance to the procedure. This was the procedure that we call hypothermal chemotherapy with total cytoreduction. We removed the peritoneum, and this they take all the disease regardless. These are 2 different cases. Okay. This one here, I have similar cause of all of the both patients I showed you before. This is the resection of the, and in this case I still have something else. I emptied the pelvis and performed the physical reconstruction. So that's it. This is the situation. Identification, pre-admission, clinic, pre-op. For the oncologic patient, this is the most valuable time that the patient has. If I can prepare the patient properly, all the rest will go on smoothly. So we have to define objectives, performance status, preliminary actions, control acid, disobstruct, nutritional support, respiratory physiotherapies, motor physiotherapy, anaerobics, selective use of nebulizers, support to mental health, understanding of the need for treatment, involvement of the family in the process, use of faith and religion as support, transfusion. This is the assessment of the performance status and the criteria for the Glasgow prognostics, talking about inflammation. If I can, since the protocol was using the physiotherapist and nutrition, I can reduce these criteria and improve the nutritional aspect, reducing the severity for that patient. If Glasgow is equals 2, the mortality related to the surgery is of 40%. Peri-op. We have the control of the pain, release of to release the use of plasma, hydration, cardiac frequency less than 100, systolic pressure less than more than 90, systolic pressure more than 90, gasometry, aggressive control of the pH, invasive measures of control. I'm gonna show this case here, which is very interesting. It's a tumor, a big one that invaded the wall with necrosis and infection. There was no possibility to treat it in a very conservative way. Can you click the surgery figure? Here we have the resection of the injury. The diaphragm was removed, and here the size of the resection. I'm gonna turn it just for you to have an idea. Move on, please. Here we have the reconstruction of the diaphragm. Here's what it looks like, what we removed. 3 ribs we removed, and this is the construction of the diaphragm. Go on, go on. This is the immediate post-op, and this is the late post-op. This is the patient today. This surgery was done 15 years ago. It's a type of activity that is the post-op. So, early start of the diet, plasma and diuretic, rational use of the antibiotics, corticoids, motor physiotherapy and respiratory physiotherapy, the controlled use of opioids, and the presence of the family. The second patient that I showed you before, she had an pulmonary embolism after 12 hours of surgery, and she was very fine later on. Thank you.
Thank you very much, Flavio. We will follow.
We'll let the question at the end. The next presentation will be the application of the baropodometry exam in the health sector by Professor Ariane da Silva Pires. Please. And Prof.
Thank you. Good afternoon, everyone. I'd like to congratulate the new professor and whole team from LaVimpi, and to thank the opportunity for being here on this beautiful event to know this technology. I'm going to pass the word from Professor Eugenio, and I would like to thank. I'm going to share the presentation with Professor Ariane. We are nurses and we are professors and doctors from the surgical department, and we act on podiatry from clinics. We are specialized on podiatry, and let's talk a little bit about the applicability of the baropodometry test in health sector. So we can have just a little bit of proximity from the baropodometry. It's an ism of image, so we can evaluate the patient. You can do a precise volunteer care statics and dynamics, and there's a great advantage from this evaluation method since I can capture all the strength realized by the body and also the position on the ground and the dynamical modality, and these came to clinical varieties I cannot see on image exams like the static exams, even for greater degree of sensibility like MRI and X-ray, and we do not use the contrast, which is safer to the patient. And this process of baropodometry exam starts on French on 1978 on Montpellier University and extends up to now through his whole trajectory. As I said for you before, we have ambulatory podiatry clinic is the first lab where we attend patients from the P.K. Carneiro Polyclinic, external ones, and interns, and we do confection of shoes and insoles, and we since this time studies been evolving, so we could use it baropodometry, or when we can use a computer to analyze the footprint and the gait and how the patients walk and the difference of the architecture, the postural architecture of the patient. We have since the decade of 70, we see a lot of applicability of these studies. We have the baropodometry analysis as a possibility of evaluation of dysfunction of the feet and postural dysfunction, and have some strength on the ground as a standing posture and sitting posture, and we saw a lot of spots on this foot, the baropodometry patterns, as we can analyze the spatial behavior, direction to the ground, so you can evaluate the balance of the patient. So it's extremely important for you can see previous identification secondary to certain disease that might affect the posture from the individual. And the device we use here is the Baroscan. There's other ones, and Professor Ariane, who did this evaluation, so we're going to proceed with the lecture with her now. Thank you. Like he said, there's no conflict of interest. We have this equipment to talk about a Baroscan is because we have experience with him. The image that we transmit here, remember a lot of tomography. It shares between the blue area. It's because it's a safe area. It's a normal one, and yellow and red start to show a risk area. We have a more strengthening with diabetic patient. It's interesting to do a prevention of pre-ulcers, pre-calluses, even if it doesn't develop more is if you can do install the you can redistribute the weight. We invest more on the prevention than in the complex treatment of the scar. There's glycemia control and the vascular control of patient, and you can bring this data quantitatively, and you see there's a little X here. It showed us the pressure in newtons is the maximum cargo that we could have there. They are being presented, and the equipment we do is more than 4,000 sensors. It costs us around 4,000 highs, and we have some of them have the double or 10,000. It's much more. And sensors are so sensible that even on statical position they can do good evaluation of stabilimetry. We can do the homework test in our evaluation, so we can have the precision to do this measurement, so we could quantify and to be precise on this load, so we could analyze the pre and post op, the minimum invasion orthopedics on the foot, and then you have exams used on physical therapy. I have the vestibular system, and this research they advanced a lot. And what we're going to do with all of this data, we keep going doing the clinical evaluation, but we are going to have an exam with much more information in this clinical analysis that we do, so we can understand how this vestibular system, how is the loading balancing in all the places of the foot, so we can do distribute better this load, or maybe you have some neuromusculoskeletal disturb, and how you answer to this balance or postural problems like scoliosis, hips rotation, weakness. And we can see a foot who have more contact to the ground, and we can do the distribution, the needed distribution that we have to do. So see the program treat the therapeutic exercise is a multidisciplinary team. We could develop a lot of treatments from this information. And the statics evaluation, this individual is standing still, and for 30 seconds you stay static. Is different from the dynamics when they're walking, so you can have morphology. You do if it's a plane or it's a curved one. You see the center of gravity. You can see the balance of the person, the type of walking. It's a prone one. It's a supine. You need to do the distribution of loading post intervention. You can see like that after the surgery. You see part of this report we had that the machine gave us here on the right. So we have here the general information, the medium pressure in kilogram for maximum pressure, the surface we have here on right, on the left. They have a series of studies, like the first one, it was from Kavanashi, who could take a grip amount of people, and you could do the individual analysis of different levels of age, and then you have the difference, and we have this previous data because of this research, so we could relate this with the type of posture that this patient could present. And here you have on A the normal individual, you have here on B slow increasing, C you have cyphos, hyperlordos, you have here on T you have other problems, and the F have all these problems. You have type of gait and type of walking and posture, and going to affect his life also. So dynamic. There's platforms that remember walking through, and you can see the dynamic, the baropodometry, and they're just walking in the ground, and you see, and can have all the information, the balance, support, all the distribution of gauge. And this is dynamics we use more, that it's more real through the distribution with this patient, and it's walking that we have this information. We have the distribution of the load during the skate, so we need to have some with a sole, a therapeutic sole, or if a shoe that we call like a respectful shoe to this feet. They need to have some characteristics, so it could be a therapeutic shoe, and to see how it stays post-op or post-interventions. Here we have a case of a teenager who have congenital foot on pre-op, and the post-op he had this result with the minimum invasive surgery. And we did, can you try to play the video? The parapodometry of her. You can see how it worked, the video. He could not touch anything. And post-op we are going to do another time, so we can see how you're going to behave after the surgery. And this how being some of literature showed us where we can use it, the baropodometry. You see he using distribution of the pressure to alter posture with leprosy patients. We have this method being used also to conduct these patients as more safety way, and we also have the evaluation for some patients with metatarsal, and how professor said before, on post-op of pre-collapse patients, we have oncology patients with a lot of problems like that, and alteration of the bone architecture, and then you have a collapsed foot, and then we do this evaluation together with the orthopedic surgery, and we do the baropodometry before the surgery and after the surgery, following the evolution of these patients. Evaluation on the center of gravity of patients with Parkinson. It's also a reality where we can use this equipment. Distribution of load in patient post bariatric surgery, especially of patients who have a gastric decreasing. So we have modification of the spatial distribution from the load on the feet, because we have some studies. Then we see the effectiveness of the method on this case. We also have advanced podometry. They're pointing to as a perspective of a future of podometry and human health. And I bring you here some studies from Dr. George Castellini. We have an event, online event with the surgery team of the minimum invasive surgery, and together with Professor Dr. Castellini. He's also a surgeon in Argentina, and they study a lot the baropodometry evaluation on pre and post op on pre-collapsing treatments of the foot. And there's a data that is really interesting that is not already published, but the Professor George said he puts really clear that the use of baropodometry has been shown and being reviewed as an exam possibilities of evaluation that now it's northing and guiding the decision taking for surgeon intervenes. So we're even see again some, if we put it the idea, if we correct the end, the back of the foot, all the foot aligns itself after the surgery. And Professor George have been seen his research on Argentina is that when he aligned the front of the foot with the middle of the foot, it could distribute better the load on the foot, and this can only be seen with the utilization of the baropodometry. Since the traditional methods of static image, they could not identify this change of load through the movement of the body. Thank you, everyone.
Muito obrigada por essa.
We will follow by the next one, entitled Diagnostic Criteria for Sarcopenic Obesity, that will be done by Alessandra Miller. Please, Alessandra.
Obrigada. Primeiramente, eu gostaria de agradecer.
Thank you. First of all, I'd like to thank all of you and the organization of this Congress on the person of Dr. Danubia. I am Professor Dr. Alessandra Mulder, Associate Professor at UERJ and Vice Director of Health Center Piquet Carneiro. We are going to talk about investigation methods regarding criteria for sarcopenic obesity. Yesterday we heard a very interesting lecture about José Lourenço. He talked about sarcopenia and he used the same image that I'm showing right now. I was watching it online and I didn't even change it because it's good, you know, to use the same sources. Sarcopenia comes from the last century with Rosenberg talking about the importance of verifying the mass, the lean mass as a predictive factor for sarcopenia. And Professor José Roberto is responsible for our geriatric clinic, and he has a very nice perspective at this. And I'm gonna speak. My speech today was be dissociated from aging, because sarcopenia now it's not impacting only elderly, and the initial knowledge came from aging populations And it showed the importance of the assessment of the lean mass, the strength. Often, strength is even more important than mass because losing mass is not linearly related to the loss of strength. So these are two dissociated aspects, and we have history showing it to us. I'm gonna talk about two consensus, European consensus, that changed short time after the diagnosis criteria. So what's sarcopenia? It's a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength with a risk of adverse outcomes such as physical disability and poor quality of life. And talking about these two consensus, when we talk about 2010, it brings as criteria the three same criteria. They only changed the order throughout time. But the 2010 criteria, it says that we have to have criteria 1, which is low skeletal muscle mass associated to criteria 2 or 3. And in 2010, we got to have the skeletal muscle mass. It was mandatory, and the cutting points, what I want to give you as a take back, the cutting points were towards absolute numbers of skeletal muscle mass. And we are going to be talking about obesity and sarcopenia, and I'm talking about an individual that weighs much more, and this weight is not only related to fat mass. And fat mass obviously characterizes obesity, but when I differentiate an obese individual from a non, this obese has more skeletal muscle mass than the non-obese. Why? Because it has to weight much more. It has to support much more weight. So if I only use skeletal muscle mass, I wouldn't find sarcopenia and obesity. So please keep in mind this differentiation. Another issue at this moment, the skeletal muscle mass as main criteria, and something else which is important about diagnosis method, because in this moment, which are the golden standards that we have in this consensus? We have tomography, we have RMI, and DEXA, which are equipments. The first two are hard to use. We can only use in clinic. And the DEXA would be a little bit better in terms of use, but it doesn't have the capacity to be used with obese individuals. Market tools tolerate until 160 kilos, and you're gonna see that IMC has been growing a lot during the last years. And from 2010 onwards, we have the consensus, we have the cutting points, and more papers arise saying that sarcopenia is something really important, but it's not, that does not regard only aging, but also other clinical conditions that take to protect catabolism. And we start to see a lot of papers talking about sarcopenia in renal conditions, in oncology, and we start to mention obesity here. When we arrive in 2018, we have the review, and they start to say maybe sarcopenia, it's not involved only in aging. And they change the classification order. They take skeletal muscle mass out as only an absolute criteria. They change this. They say that the first criteria would be now the strength. But we have other problem here, which are the cutting edges that are placed in this consensus. the cutting edges to aging population. And it's different when I talk about the strength of a person, of a 60-year-old person and a young person. I cannot compare even a 60-year-old person with an 80-year-old individual. But the 2018 consensus published in 2019, it says that first we have to assess strength and then confirm with the loss of skeletal muscle mass. And then it starts to propose that this mass should not be only assessed in absolute terms. I can start to assess it proportionally. And proportional to what? To weight, to IMC. So I'm going to start a correlation without this giving, a final understanding, a final response. So we're going to have independent studies talking about cutting points, and it makes sense in obesity because the individual has more skeletal muscle mass, but when I correlate it to the whole, it's not so much mass. The individual has more mass, but it's not proportional. This mass is bigger, but it's not compatible to the patient's size, to the patient's body. And we start to see another terminology arising, muscle quality. It's not only about having more mass, but what about the quality of the muscle mass, of the muscle? And now we start to assess muscle quality without using ultrasound. And even though ultrasound is not invasive, but it's more expensive. And this quality mass, it's a reason, an equation, and it's a reason of mass that involves mass. And if we start to think of sarcopenia and sarcopenic obesity, when we think of the main factors that contribute in sarcopenia and sarcopenic etiology, we have bad nutrition, malnutrition. But the malnutrition, you're talking about obesity. But who told you that obese are eat well? It doesn't mean that the fact that he weighs a lot doesn't mean that he eats well. We're talking about loss of weight, and when I think of sarcopenic obesity, maybe in the pre-op, this might not be a problem, but in my practice, I work with bariatric surgery, and this might be a problem to me when I'm following up with my patient. Regarding sarcopenic, again, we have the lack of exercises, or even better, the sedentary behavior, because many times sometimes we even exercise, but we have a sedentary behavior as a whole, in general in life. Every event related to this condition, anabolic resistance, this could be related to obesity, especially to insulin resistance. Chronic inflammation, we know that obesity is a disease with a low degree of chronic inflammation. We know that obesity is related to chronic conditions. So when I talk about hypertension, diabetes, so easily, and now I'm quoting Coletta and Phillips, we could place an obese in the center and not necessarily an aging individual, an elderly individual. And I bring the same etiological factors. And we arrive to the concept of sarcopenic obesity. It's a clinical and functional condition characterized by the coexistence of obesity. So I need to have an excess of fat and fat mass associated to sarcopenia. And it's related to strength, to physical function, And in 2022, we had the first consensus to try to create criteria to assess the so-called sarcopenic obesity that was established by ASP and EASO, ASPEN and EASO. I forgot the word, but they are European. I forgot the names. And they define sarcopenic obesity by the combination of obesity, body fat, and sarcopenia, defined as low skeletal muscle mass, accompanied by low muscle function. And now we have some interesting aspects. They are different from this consensus because before we were already talking about sarcopenia. So they places diagnosis algorithm and start talking about the screening and the assessment. What does screening say to us? First of all, this individual needs to have an BMI for obese populations. When we talk about BMI, this is the BMI from the WHO, and often we stop at degree 3. That would correspond to a BMI of 40, but now we cannot be stuck there. We see people with higher BMI, and we have to speak properly about the higher BMI. Before we were talking about super obesity and obesity, but this was published by the WHO in 2000. But since 1994, we've been talking about the class 4 with BMI from 40 to 50 and up to 60, and above 60, it's a BMI for super obese. So 1/4 of our population has obesity with a BMI that equals 30, and we have 40, and we have 70 in our daily life in a health center. And where do they come? They come from the CISREC line, waiting for someone to treat them. And sometimes they are in CISREC without any treatment, just waiting for someone one day to operate them. So during the screening phase, first of all, they gotta have BMI alteration and a hip circumference, an enhanced circumference, and we are talking about 94 to 8 for men and 80 for women. So let's think about this hip associated to other sarcopenia parameters, such as slow gait, fatigue, excessive fatigue, which is not rare in obese. They say, I walk just a little bit and I felt tired. Besides, we have questionnaires like SARC-F, but for people with obesity, the young people, SARC-F does not work. So I do not recommend it because it was made for the elderly, and we have used, and as a screening, it does not work. Then we go to the diagnosis, and it says a diagnosis should be performed in 2 parts. First, assess muscle strength, and it mentions 2 forms, 2 ways to do it. Through dynamometry, so assessing the manual strength, and I need an equipment, the dynamometer, and but there is a simpler test than this one, which is sitting down and standing up 5 times, the chair stand test. And I only need a chair without arm. I ask the patient to sit down, to cross hands on the chest, and to sit down and stand up 5 times, and I'm gonna register the time. And you may ask me, which are the cutting points? And this is the great discussion of this work. It doesn't give you the cutting points. It gives you an appendix with many cutting points based in different ethnic groups And it says also that cutting points for strength have to be validated from using gender, ethnic, and age, ethnicity and age. And we start to see that in patients that are obese, that maybe they have, hand grip strength, and we were not finding the other parameters. I have so many articles saying this. We would ignore it, regardless if they had strength or not, because then I would find quality, muscle quality, in more than 70% of the population. So which are these methods that we use to assess these patients? Afterwards, after the strength, the assessment, and the classification, then I can assess the body composition. And if you see the image, they don't talk about EXA, they don't talk about computerized tomography, they talk about bioimpedance, which is a less expensive, more economic exam, faster, and able to be used in a health center. We have several equipments. Of course, for research, we're going to get an equipment with more quality, but if you are in your office, in your daily practice, your bioimpedance scale can be used. And we have limitations for all methods. And that's what it says, that we're going to assess the fat, the increased fat, but also the appendicular mass, the skeletal mass, which is the skeletal muscle mass of superior and inferior limbs, related to weight. This W is weight. I don't assess these measures from an isolated perspective. I will see them together. I'll relativize, and I will have several cutting points. And they don't have this physical performance as a criteria for sarcopenia. And they talk about a third moment, that will be staging. I will see changes in strength, in skeletal muscle mass, and see if the patient belongs to stage 1 with no complication, no metabolic disease or disorder. And we are starting to talk about individuals with obesity with no alterations in exams, but maybe they already show sarcopenia symptoms, although they don't have metabolic disorders. And we have stage 2, the presence of at least one of complications attributed to SO, which could be metabolic, cardiorespiratory. This is an article that we published in 2011, before 2021, before the 2022 consensus. And the big issue here is that we would see the excess of skeletal muscle mass here, women that had more than 50% of fat mass, men with more than 50% of fat mass, and all the relations with muscle mass altered in these patients. And since we were in the absence of sarcopenia was none, and we suggested to relativize these articles, even mentioned in other congresses, because it takes you to think of this relativization, showing that all the early diagnoses protect and lead to a better quality of life of the patient. And if I think about it in terms of obesity and my patients for bariatrics, the better I have it, the patient before the surgery, the pre-op, think about it, and how can I get this skeletal muscle mass in time. So we are assessing how this sarcopenia can behave during the post-op, focusing on in what type of interventions we are performing, dietetic ones, physical activities, so that this individual won't have consequences after the surgery that might lead to other conditions. Thank you. Thank you. Thank you, Alessandra. Let's to the last presentation. Gente, tá atrasadíssima.
Good night. It's last lecture. My name is Renata Alves, and I'm professor from Psychology University from UERJ and from PUC Rio. And I have a mission, very difficult one, to talk about evaluation on child and teenagers, neuropsychologists, and how we do this neuropsychologist assessment. We have a very expensive exam to the public health sector and have most of clinical picture. It could be beneficiated by good evaluation, neuropsychological one. And when we do this in our clinic, we need a multidisciplinary team. Most of the times I'm going to give the evaluation, so I'd say to go to phono and the psychopedagogue. And we need to understand about development. We talk about kids, and we start evaluation most of the time with babies. It's going to be complicated to talk about it because I have specific evaluation for the baby, a preschool kid, and also for the one who already are on the school. So I'm going to be a little fast so you can understand how complex it is to specialize in just one area, because we have a lot of material, and at the same time when we work with small kids, we need to understand the systematic development. Most of the time the behavior is going to be adaptive, like the THG is going to be actually everything that's going to happen in his life cycle is going to influence. So I need to look at the age of the person, because you might have relation, you can see the biological aspects, some pictures of genetics. We are knowing now there's alterations there, or even brain injuries in the environment that this kid were inserted. It was stimulated or not. If it's overstimulated kid, maybe when you have a evaluation, you could give a good score that a kid that do not have even a school or extracurricular activity. And when I talk about kids, we need to know about the atypical and typical activities, the free development, and even the manuals we have. At the time we have the sensitive and critical periods of life, because a kid's evaluation every 6 months you have a lot of difference on the development. If you have any lesions on neurodevelopmental, like cranial traumatism, or have an injury, and the neuroplasticity and the vulnerability of this kid, you have any disorder or genetic alteration, this behavior is appropriate for the age for this kid. You might see a kid who are adolescents who are on the second infant behavior and see the brain maturation of the kid. And our theme is up to the teenager. Let's talk a little bit about the first childhood, so 0 from 3 years, second childhood from 3 to 6 years, and third one up to 11 years. How we do the assessment steps with the report from the family and the kid, because the kid needs to be cooperative and we could not complete the tasks we need, have typical or atypical aspects of development. What I'm going to assess, most of the times the family is started to say about something, but it will may have other things to evaluate it. There's other problems to work on, and then you have to do assessment preparations, psychological tests. Most of the time you need a specific protocol that are more sensible for each case of the patient had. So you need to see the hypothesis, the assessment plan. You need to have a test application, a quantitative and qualitative analysis. You're going to generate results. You're going to have a report, and then you give the feedback of what you find out. And when we think about TSM, what you think is a disorder, intellectual disorder, communication disorder, autism spectrum disorder, ACED, speak learning disorder, motor disorder, or even others, neurodevelopment disorders, or even genetic syndromes, because family do not have a treatment or something we do not know. So I need to think beyond the neurodevelopment disorder. There might come psychiatric disorders. If the person has a more difficulty of learning, I can have anxiety, depression. Now we do not have a tool to validate it, so we can treat anxiety on kids. So our evaluation needs to have a behavior analysis. Now we have a history of what we should do, is what I said before. And then you need to have the patient history. It's an anamnesis we should do. It's a medical one and also psychology one. You need to ask the development, how it was the gestation, how was the behavior of the family, who takes care of the kid, the routine of the kid. So we take one or two consultations just with interviewing. And I have 3 pillars. I need to see everything from humor, the anxiety, the mood state, the behavior, and see if there's any difficulty or the ability on cognition. And I have here cognition, attention, memory, language, perception. I do not do neuropsychological with just one task. I need to see how much of these are altering their cognition and what came first. And this is heterogeneity cause that will compromise the quality of life of this kid or teenager, and this kid could not be have support from the family, not just caring, but the public health. And we have a sensory profile when the kids on the scholar time. We need to know about it. If this case is that who is going to talk, is the caretaker or the responsible or the parents. So we need to be really careful, because sometimes the person not know what you're asking, and there's divided with a small kid. A school also can answer it because it's another view from it, and it has an index with a lot of areas, so you can see that this kid is inside what is expected or not for his age range. And Denver 2 is a test use even smaller kids to find out about autism spectrum, and have this little kid and you see the development. Do not have a diagnosis report, but you can see the mapping of the alteration the kids have. The Bailey it's a baby review. It has also this test. Most of the times you need the company do a donation so we can work it, and use a lot with the babies or little kids. Most of the time people specialize to work just with baby. I do not do the evaluation with babies. I prefer to do with preschooler, but also attend adult and elderly, and evaluates the language, motor, and two important parts as social, emotional, and adaptive. This is also a scale for kids from 9 years to 11 months. And Colombia, see the abstracts, recognition, and when you see inside the public health or a university, you have this kid with the difficulty to have an intelligence scale, so it's your maturity range because it can have some developing problem. When you go to preschool, you have this test. You can see some abilities of being the speed of processing of the kid. You can do a copy of the drawing. You can do any count. If you have any ability to the phase of scolarization and the adolescents or the teenagers, have SRS2 that you're going to use on the research. It's a scale which defines autism spectrum disorder. There's a relate or any parents who is going to do and the self-report of the patient, and then the school and the responsible ones is going to answer. What I usually do, parents answer it separated because what one sees the other do not see. Most of the times one minimize and the other maximize it, and the school also answer. And when you're adult, you made the adult answer and someone who lives with it answer it. And he gives this graphic. Most of the time, if you have more on this side, have more compromise on the social abilities. And these some variables of the test. The violent is another scale who goes up to 9 years of age. It's the adaptive behavior of the kids. It can have a motor or behavior disorder you can use on the sense. This is a scale from CBCL you can use from 6 to 18 years. Evaluates conduct problems as social skills in kids and adolescents aged from 4 to 18 years. When questionnaire we have is carried out by parents or teachers, tracking the behavior and emotional characteristics. SSRS2 go from 6 to 13 years old, involve primary education from the 1st to 5th year, involves social behavior and academic competence. And you're going to have all these variables, and each of these person will answer, and it helps you a lot if the school has the same view from the kids and if the parents is seeing the same thing. And with the increasing of ACD, you need to have answer also. And when you go to see report, it's nice to see graphic to see if they are agreeing with the parameters from the scale. From 2 to 12 years, 17 years, they answer a scale that is different when it's adult. When talk about children, we cannot say personality, but you can see some traces of personality. There's going to help the psychotherapist or even the guidance. If there's a trace of extroversion or even introverted person, and there's some diagnosis and even more problematic on the treatment. The idea of this evaluation see the maximum and minimum behavior we had, and this for kids from 5 to 10 years, and there's other tools for behavior assessment. It's a little bit different because you have a teenager from 10 to 16 years, even if there's only 10 and the other scale is also for 10 years. And when you're going to talk about kids, the parental style inventory, how does kid see his parents? Which type of parenting style they have? Is a neglected father, is very authoritative father? You see the perception of the kids from the parents, and they also answer what the style of education they give for the kids. So you see a lot of parents that hit the kids or evaluate yourself in a negative way. So you see a qualitative that you can use to intervene and treat. Social ability, even because of diagnosis of autistic disorders, you use this to complement the diagnosis. There is for kids and have a version for adults. The back to depression inventory is just for kids up to 10 years. It's a self-answer. The kids need to answer with the psychologist because some questions is difficult for the kids. So do not give the diagnosis because it's a clinical, but you see the symptoms that this kid have, and you can see the amount of symptoms and the picture depression the person has. And there's other one for 7 for 18 years. And we have now material for depression, but it lacks of anxiety. And we use the maximum because it's not validated only in research, but it talks about if the kids has a lot of phobia, their separation anxiety, which of the symptom is fulfill better. And there is has a high ability and kids, and how we have a lot of kids with high abilities and a spectrum of autism could also have with this, but this is scale it's just for kids, but we need to do in adults either in interest and motivation, persistence and perfectionism, leadership and self-confidence, a lot of creativity and imagination. We use human figure drawing. There's a drawing of the human figure. You analyze personality and the drawing of the family, and the way you do the drawing, who is small, who is bigger, it reviews a lot of things from the personality. And when there's no test of personality, you can do this when the kid is too small to write it. In the vascular intelligence scale for children is as risky because it's expensive. And if I have a kid is preschool, You can use it because of the capacity of the person, and then you have the Pearson scale. We have also non-verbal intelligence, and so on are, because we're going to use it here in the lab because it's go from 6 to 40 years. This scale is going to analyze intelligence from non-verbal one, and we're being the first choice for non-verbal autism from 6 to 7 years old. And we do it also on diagnosis of autism on adults and nonverbal intelligence tests from abstract intelligence, so we can identify high intelligence. The kids who are smarter, they can use their abilities on other tests, and other tests of intelligence. You see attention assessments. You see the family have less concentration, more concentration. You have a part of the humor and psychiatrist, and the other is cognitive. And so we can close now. You need intelligence and the other functions, not the connectivity functions. You need to have observation, customer history, family history, scales, and tasks. And only from then you gather all this information. You're going to do a report so you can show the abilities and difficulty that this kid might have. Everything is from learning, relationships, and maturation. It's linked because the limitation of some function or the behavior of the kid impacts the quality of life of this kid. Even there's a question of a kid could not do a routine, could not take a shower, need help to feed herself, and you need a bigger intervention who is more adequate. So in this case, you do a following orientation, and we are going to suggest the better interventions in each case. Just to end, this is my bibliographical references. The development books, they are important. The old books, they had a lot of difference. And related to the age range, it's better to use the newer books and see which is adapted more for the age range you study. And that's that.
Thank you very much. Now I will invite the speakers to come here to the stage. Vocês têm perguntas, por favor? Ih, eu tô falando.
Para os professores aqui.
You showed the use of baropodometry, if you can use it in SUS, in the public system, if you can use orthosis. I'd like you to, elaborate a little bit on this, for the public health system. Unfortunately, we still don't have this exam, this test and the exam and this table. We have the PPC. I don't know any other unit that offer. We acquired the equipment through courses and doing some fundraising. And I have some podiatry students, and I have municipalities' proposal to try to put these tests in primary care, but I don't know how this is going to be done. They asked me for some specifications, since Baroscan is one of the least expensive and has a very friendly software, and updates are not so expensive. And we opened 6REG. We had a lot of referrals from all the state and from further regions, demanding this test. Orthopedics were asking this assessment for the exam, for the test. But in 6REG, we were added, since we don't have baropodometry in SUS, we'll see if we can integrate it as an image exam, because the institution does not account for this exam, does not have any financial registration of this exam. But we work with insoles and ortheses from superior limbs that were being referred to this, were being referred to with this name. People were looking for wheelchairs and ortheses that are not from superior and inferior limbs. Thank you for your presentation. I have some experience with patients with diabetic feet. I use a platform, and the problem is that many patients use a plantar option above 100 newtons, and this is a limitation for the equipment that I was using. I don't know if this is current in your assessments, and if yes, how do you deal with it? It's a problem for research and for assessment, and we cannot give the proper value because it goes beyond the gap that we have. In our reality, this is not so frequent, but it's a limitation. It exists in the equipment. And when we have this limitation in the equipment, what we can do logically is to give a clinical follow-up. It's the off-label situation. You admit you have a maximum pressure of 100 newtons, and from that moment on, you start to adjust in off-label mode. One last question then to Professor. You talked about this difficulty in using all this technology to research and investigation in children and teenagers in the public health system. But I'd like to know if you know any perspective or something that is going on so that we can facilitate the access nowadays. The amount of children that have late diagnosis, that's the real demand for incorporation of this technology. Do you have any information about it? In Fernandes Figueira, we perform an assessment with babies because of, I forgot the name of it. It's babies were being born with conditions. They were preterm. No, one of these pandemics that we had. It was microcephaly, because of Zika virus. And there, they created an assessment protocol to follow which would be the needs the children, the babies would develop, because many of them don't have cognitive conditions, speaking conditions. Here in this health unit, we are receiving many patients with late diagnosis of autism. They come with the referral for assessment, and the network, it's trying to respond to this demand, but the problem is the value, because it is the cost. You have to create an ambulatory, and people start to use the public scales because you don't have this problem of copying, Otherwise, you have to buy the test and use the scales according to each program. But in this case, the better thing to do is to create an ambulatory for a specific frame, because you cannot, handle everything. And if TEA or COVID protocols are being created, this is a movement for you to have this type of assessment in the public health system. So, talking about Zika virus, we in Pernambuco were working with it. We didn't know how and why we were receiving so many children in Recife. And we were living with it up until now, because there are many children. We achieved through politics, through a project of a congressman, we achieved that these children could have assistance, specific assistance in our department, the physiotherapy department. We welcome so many children like this, and we fight, and we achieved it, and we will have assistance for corrective surgery because they really need it, besides all the types of assistance they need. You are not alone in this fight. We are there at the Northeast, but the problem is the same. It regards assistance, because we still don't have the sensibility. That's what I want to say, and congratulations. Thank you very much. We will finish this session.
Now it's time to give a certificate, yes, and the gift and the photo, yes. Please.
Thank you.
Please.
Dá pra você divulgar só um pouquinho? Ei. Bom, a gente vai caminhar então agora para a cerimônia de encerramento. Vamos fazer uma... Ui, desculpa.
We're going to move on to the closing ceremony, and I'm going to call the presidents. And please don't leave, because we have the prize draw and the prizes and the awards. Let's see who is going to win. I had the honor to preside this year the Mevitih 2024, the Congress about mechanical vibration and technologies in health, together with Professor Heda. Where is Heda? Don't go smoking. Come back. Don't smoke now. Okay. Well, this Congress is a joint Congress, and one of these is the third Congress of the Brazilian Association of Mechanical Vibration and Biosciences, presided by Mário Filho, please. And we have as vice presidents Francia Constant Boyer, who went to smoke. Francois, come back, please. This Congress
do terceiro Congresso Internacional
also received the third International Congress on Technological Innovations in Health, presided by Dr. Elisa Sonza, please. With as Vice President, Dr. Adério Seixas. Since I said so much in the opening ceremony, I'm going to pass the floor to them now. And we still have a State University representative. Can you put a chair here for me, please? I'm going to invite Professor Dr. Norma Barello to be here with us. She's a Brague's director and will represent the State University here with us. So I'm gonna give the floor to our Vice President, Professor Hedat Taya. You have 2 minutes.
The Congress and your impression. You'll give it 2 minutes.
2 minutes.
Feel free. In Portuguese.
I will translate after. But let me tell you, I promise the next time I will come with 20% of my discussion in Portuguese. I promise. It's my motivation. I come since several years with the invitation with my friend Mario and Danubia, and it's a big pleasure. What I saw during the Congress is we have the connection between people from abroad. It's a pleasure for us to come here to know different area, to contact also different approach for the research. You know, the research is something very complicated, and we must share the knowledge between us, between a researcher coming from the research is international, and to be here every time it's a big pleasure, and every time I came with motivation, and this motivation increased by the different exchange, because also during the year we have the possibility to exchange by email, and I hope that this Congress also increase every year by the group here, also by the surface what I saw in the lab, and this it's not the results of it's a result for the very hard work. And I would like to tell all people thanks for Danubia, Mario, and all the colleague students, and they with the big help, because they have the big place to have the good Congress, and that's all. Thank you very much, and tout de bon.
James. Thank you very much. I'm going to give the floor to the president of the Congress of the Brazilian Association of Mechanical Vibration, Professor Mário Filho. Take your time. Wow. So, before everything, I would like to congratulate Professor Danubia for the organization, the dedication, the way you conducted this event. Congratulations, Professor. It was really amazing. Well, I hope you continue vibrating with the vibration, the mechanical vibration. In many lectures, we spoke about this mechanical vibration, but in others, mechanical vibration has always been present. And we have an important issue. As one group decided to create an association, a Brazilian association of mechanical vibration bioscience, this has been following a tendency because of a congress that we organized in 2016 in Cabo Frio, where many colleagues from different countries were there and attended. And we created a world association, a WIVEX, a World Association of Vibration Experts. And during this meeting, this congress in Cabo Frio, the whole world was sensibilized. And when I say the whole world, we had colleagues from at least 10 countries, and all of them were unanimous in saying about the importance in studying mechanical vibration. And this is not only in Brazil, it's the world's interest. I don't know if you followed the potentiality of mechanical vibration. So this association in time, that's what we discussed. And in 2019, in a congress that we organized, the Brazilian Association of Mechanical Vibration and Bioscience. And this association is for everyone. It's for you. It's for the world. So this is a way we were trying to project the knowledge we were creating in Brazil and the importance of this association. I don't know if it sounds familiar for you, but there is the meeting of experimental science in Brazil, the FESP, and next year, Professor Norma, we were invited to attend it. The association will be participating, will be attending this Congress in Campinas in 2025. So there is a recognition from other bodies and scientific institutes regarding the importance of the mechanical vibration. And the idea is to evolve, is to advance. If you are not members, it's easy. The fee is really symbolic. So coming back to this event of the Mechanical Vibration Association in 2024, we talked about so much applications, innovations, technology, and there is a potentiality, a potential for this issue in this area. And it was pretty clear in this Congress. And I want to congratulate Professor Danubia and each of you, each of master students, PhD students, undergraduate scientists that allowed us to prepare to create this event. So I would like to thank you on behalf of Professor Danubia and for all your effort to make this event happen, being so incredible as you saw. It's hard to have so many people in a closing ceremony. It happens because you are really interested, and it shows how important is the work that we have done, led by Professor Danubia. So, Professor, thank you for including the Mechanical Vibration Association here in this event. And I invite you all to 2025. We already have the date. We already have the proposal. We have submitted the proposal for funding for 2025's event. Again, thank you on behalf of the Brazilian Mechanical Vibration Association and for trying to collaborate with us. Professor Francois, would you like to say some words?
First of all, I want to thank Danubia, the Polyclinic and the university, and Mario and all the organizers, because it was very great and I'm very impressed by your vitality in Brazil to make research. And it was a very pleasure to be here with you. I think I come next year. Perhaps you excuse, I'm very sorry for my English, not very fluent, but perhaps next year you can have IA to translate French in Brazilian, and it will be... Yes. But I thank you all because I think it's very good meeting. And I'm very happy to be here with you. Thank you very much.
Thank you very much. Thank you. Agora, eu gostaria de passar a palavra para a professora Annelise, que está...
Now I'd like to pass the floor to Annelise, who is presiding this third Congress on Technological Innovations in Health. I'd like to greet, first of all, the president of the event, Dr. Danubia, and all the members of our table. And on behalf of the third Congress of Technological Innovations in Health, I would like to say that these days were really intense. We had discussions of extreme importance about technology to be used in several fields, from diagnosis, treatment, the follow-up of our patients, and in the end, this will bring quality of life. So technology is really important, and we need to aggregate it in our daily practice. We're waiting for you in 2025. Thank you very much. And I hope we have more and better discussions next year. So please, Professor Seixas, there's nothing more left to say as the last person. So in first place, I thank Mario and Danubia. But in 2017, I received an email from Professor Maio Bernardo Filho saying, I read your research about this, so can we establish a partnership? And from that moment onward, it has been very gratifying. It's the third time that I've come here, and always when I come, I learn a lot. Thank you very much for your invitation. I'm vice presiding this event, and we have some innovations here. We have all the international broadcasting. It was really different, but it was very good. And say to Nubia and Mario, they have a fantastic team, focused, willing. And without all this work, this event wouldn't have been possible. So thank you very much for your invitations, for being here. Now I pass the floor to Professor Norma Barella, representing IBRAG and UERJ as a whole. So good night, all of you. First of all, thank you for this space. It's an honor share this table, informally constituted, but on behalf of the Institute and in this moment representing our state university, it's important to say about the relevance of these three events and the opportunity that the university had to welcome them. Although they have an essential access, we have the transversality of these themes and they're reaching in terms of knowledge to our students, undergraduate and post-graduation students. This is our vocation as institution, so we're very happy and honored and thankful, especially to you, Danubia, because this is one more event that you coordinate and organize. Not only of this nature, but you have brought many proposals, many nice things to our institute. So we're very happy and satisfied to see the event is finishing with such a positive result. I'm sure that out of here, from this moment, we'll have many different ideas, and especially in terms of public knowledge and public institutions. So let's move on to our prize draws, and I'm gonna be fast. So as you all said, nobody works alone. People who work directly with me know how I value you all in my daily practice. So I have to thank you all for your partnership with me. All of you, even when I'm not there and I decide to participate at a public call at last minute, people call me and ask me to sign papers. I'm always ready for that. Professor Mario, who started the idea, and we are receiving the results. Many partners, as Adérito, he saw the publication. We asked him for a partnership. These are things that we did not do alone, and you were the ones that dedicated time and effort for this event to happen. We've been doing this for at least 1 year, working hard for this event to happen. We have undergraduate students, post-graduation, PhD students. Josie, our little gift. Everyone bothering Jose every day. People say that we have to come with the list, because everything they ask me, I say, talk to Rose, and she already has a list of what she has to do. I would like to thank you, all of you, as I said in the opening ceremony, all the professors that came here. We had the idea to do a low-cost event, and how do you do it without money? So we have numerous friends here who came us without any payment. They are paying for it, for their flight ticket, for their hotels, for their food to participate, and even brought other people with them. So I have to thank you so much. You wouldn't be able to do this event without each of you. And now I will ask, as Professor Norma arrived, she will choose a number from 1 to 88. 40. Marco Antonio de Souza Gama, are you there? Next. 30. Andrea Ferreira da Silva. The last prize draw. Run. This is how we improve the need. We don't need a platform anymore. It's just to give a prize and someone will come running. Which is, where do we start? Where's our list?
Bom, a gente fez esse ano concurso.
So this year we started a conquest. The contest, the event moment, we asked you to take pictures and post it in social network, expressing our spirit, the event spirit, and as we said before, we would give the prizes if people would be here, but some people made group pictures, and The group doesn't need to be here all together. Even if one person is here, we're gonna give the prize. So the prize is going to the person who posted the picture. These are our guidelines. So in third place we have Andrea. You posted. You didn't post it. She posted it. Second place. This was a video. She was vibrating in the platform. Good vibrations, she wrote. Thank you. I didn't participate in anything. I wanted to post a video, but people said I couldn't. I was forbidden because it was an interest conflict. In first place, Thaís. Mevitih in sign language. Since Thaís is not here, is there anyone in the group? Larissa. This prize is from a sponsor. This is Paperge's prize. Very well. Is there anything else? No? Já passou bastante.
A gente teve obrigada, meu amor. A gente teve empates, né? We
have some draw here regarding the banners, and we decided that we would give the prize. Remind me of who is going to participate. It's 1 first place, 3 second places, and 4 third places. And you're gonna have to help me remember them. It's in my cell phone. It's a lot of information. Who sent to me? You? So let's go. So I want the prize, the certificate. Where is it? Ai, não sei.
Pronto, obrigada. Tá na ordem, não? Bom, nesse ano a gente decidiu que não faria só
This year we decided that we wouldn't give award only to posters. We're gonna pay homage. So our prize is called Professor Dr. Mário Filho. And you are going to hand it.
Bom, tá na ordem aqui então.
It's in order, so our first place goes to we have 3 second places. Mas o Uber.
A pessoa não enxerga, cadê o negócio? Aqui, ó. Eu vou ter que operar a catarata igual o Mário. Oh, Jesus. Priscila Moreto, Gabriela Lavarda, Natália Liseu e Rosane Rodrigues. São 4. Dá-lhe para ele entregar. O Mário vai entregar. Vai lá. Priscila Moreto, Gabriela Lavarda, Natália Liseu e Rosane Rodrigues. Ah, cadê os presentinhos? Obrigada, meu amor. Aqui, ó. Peraí, tem a premiação. Obrigada. Não, menina. Ah, tá. Achei que você estava dando os outros já. A enrolada sou só eu. Cadê? Muito bem. Vamos lá. Não é marmelada. Cadê? Me ajuda aí. Quem é o segundo? Eu vou virar meme, não, né? Já virou. Ô, Cristo. Cadê? Bom, o segundo lugar, então, a gente tem Gabriel Siriano, da Marcelo dos Santos.
So second places are
Bandeira Dionísio Cardoso. Ainda bem que eu não participei de nada disso. Nem o nome eu conseguia ler. Espera aí, que tem eu também. E olha que eu não bebo, hein? Aqui. Tá. Hã? Ela falou que vocês vão ter que dividir, que vocês são namorados, vão ficar com uma só. Aí, ó. E agora, quem é? E o primeiro lugar, quem será?
and first places are
É marmelada isso. Ela vai vender o livro ali na esquina. Não, o livro é da Thaís. Ela vai guardar pra Thaís. Deixa ela no meio, que ela que ganhou o negócio. Fica bonitinho. Peraí. Não tenho mão. Ah, mas por meio. Bom, muito obrigada mais uma vez por vocês estarem aqui até esse momento. E, como o professor Mário falou, nós já submetemos o pedido lá para a CAPES, para ganharmos, se Deus quiser. Foi o CAPES CNPq, já nem sei, porque eu vou submeter para tudo que aparecer, mas acho que foi CAPES. E aí a gente já está no nosso evento do ano que vem. A gente precisou colocar 4 dias, porque a gente tem mais palestrantes querendo palestrar do que dia. Então, como foi esse ano, vocês viram que a gente incluiu umas pessoas, né? Então, vai acontecer nos dias 4, 5, 6 e 7 de novembro. Então, já podem reservar na agenda de vocês. E encontro vocês aqui no ano que vem. Muito obrigada.
So next year we're going to have the same event on 4th, 5th and 6th of November. So see you again next year.